to obtain the maximum safety margin. How to treat with the mediastinal, abdominal, and cervical groups of lymph node. This may be changed according to the squamous type or the adenocarcinoma type. In fact, what's the literature agreed on that whenever the histopathology is a squamous cell type of carcinoma, extensive lymphatic dissection of proximal and distal to the site of the tumor should be performed, while adenocarcinoma considered to be less invasive from the point of metastasis to the lymphatic groups of lymph node. For surgeons, again, the degree of ischemia of the gastric tube that been developed and formation of the new gastroesophageal anastomosis, whether in the posterior mediastinum inside the chest or in the considered to be an important point, because these patients may have relatively ischemic transpositioned stomach, other conduits as well, while the problem is that it may end by stricture. The stricture could be benign or malignant, or it may end by leak from the stricture that it is relatively a catastrophe in the postoperative period. So in our center, we started to doing this surgery almost 15 years ago. So we started to collect AO data. In the beginning of we started to do Iver-Lewis, means 2 incisions, thoracotomy and laparotomy, but later on we found that there are certain patients may need more safe margins proximally and distally to the tumor. That's why we think that why not we adopt transhiatal resections. So we go to the transhiatal, means doing laparotomy only with cervicotomy. So in these two, we could do railroading behind the heart, behind the mediastinal structures, including the carina, left main and right main bronchi, to go to the neck to do a cervicotomy and to do gastroesophageal anastomosis there after complete releasing of the stomach and extension and doing pull-up to the neck. So we adopted some criteria to develop either transthoracic esophageal excision or transhiatal. So we didn't know in the beginning which one is better, so we started to collect the data. So our study was comprising 87 esophagectomy over 13 years, means since about 2007. So it's a prospective collection of the data between 2 groups of patients. The first group is transthoracic esophagectomy Iver-Lewis operation. The second one is transhiatal esophagectomy, orange ears procedure, means doing laparotomy and cervicotomy without doing any sort of thoracic, but keeping in mind that all of these were combined by massive or extensive lymph node dissection in the mediastinum, in the abdomen, or in the neck. Later on, we regularly followed the patient after 3 months, 6 months. This means if the patient survived and went out in the hospital. This data were registered in the research registry at a number of 5755. All the esophageal resections were for curative intent. That means we try to keep the minimum of irresectable tumors inside this paper. All the patients confirmed to histopathological examination of esophageal cancer prior any sort of intervention, and we arranged our paper on the guidelines with Storkas guidelines. Just demonstration how we did TNM staging for all our cases. We used TNM classification, included all clinical tripartite assessment of these cases that we did local regional staging of the cancer, and we did again clinical staging that the patient's performance status, cardiorespiratory status, all this has been evaluated prior to the surgery. Any patient with a poor performance status or tumors more than T3, in fact, later on you will see we have some T3 tumors inside the series. We try to exclude them from the study. So how we choose the approach? For the transthoracic approach, we try to use all the types of lower third tumors. Any previous irradiation and extensive mediastinal lymph node dissection was required, so we prefer to do that. Any tumor more than 3 centimeters in size, we try to do transthoracic approach. While for the transhiatal approach, tumors of the upper and middle third, less extended lymph node dissection, means earlier stage of cancer has been used for this approach. Whenever you're longer safe margins, you know that the safe margin in the esophageal surgery is an extremely big problem for the surgeons dealing with that. We need at least 5 or 10 safe margins proximal or distal to the tumor. So I think transhiatal will be perfect for that, but for the lymph node dissection would be not. Longer safe margins, small diameter tumors, and cardiorespiratory status when the patient has severe COPD or other ischemic heart disease that making the patient's performance status or the pathophysiological or the physiopathological reserve is not fit for Iverluse operation. We try to use transhiatal approach. So these were our characteristics for the patients. That the gender, you can see frequently there is male predominance in both groups. The age, you can see that between 60 to 70 is the maximum type of the patients in both groups. That this is transthoracic group and this is transhiatal group. The comorbidities, hypertensive was associated with many of these patients. That in both groups, hypertensive patients were. What's the link between hypertension and esophageal cancer? I don't know. Probably one can explain it for us. Clinical stages 1B, 2A, B, 3A, and B even we find it. Now the B probably you may ask me why I included this in the surgery. In fact, should be not here. But these are the lacks of facilities, and at the beginning of the experience, some of these patients we have no EOS. So for that we are diagnosing or staging the tumor by CT scan. As you know, that CT scan is not the ideal tool for diagnosing the tumor or the state of the T. So that's why we were misdiagnosing these. These are relatively a heterogeneous group. The types are squamous cell carcinoma in 35%, in 47% of the cases in the transthoracic, while only 24%. Adenocarcinoma 12, 16 in both groups. According to the stages, as you remember, still the resectable stages are relatively very good for both groups, transthoracic or transhiatal approach. So we are still in the, let us say, in the curative intent for these. The intraoperative approach that we have relatively, if you compare both groups, regarding the time of the surgery, regarding amount of blood loss, intraoperative complications, IUC, intensive care stay, hospital stay, all these were relatively similar in both groups. So this type of comparison showed no any sort of priority for any of these groups. Strangely, you find in both groups that, for example, in the transthoracic approach, we suffered a reluctant hypokalemia. In these cases, despite all the measures for replacing the daily supplements of potassium, that we never were able to correct this hypokalemia. We searched too much in the literature that we couldn't find any answer why our patient had severe hypokalemia in the transthoracic approach in comparison to the transhiatal approach. We never faced this. Wound infection has the same rate, pulmonary complications, the same cardiac complications, the same vocal cord paralysis very high in the transhiatal approach because we are manipulating the left recurrent laryngeal nerve. That's why we may face this. In hospital mortality, transthoracic approach 9, while transhiatal approach. So the mortality with less significant statistical appearance is being superior for the transhiatal approach. This is a bit statistical bias that we manipulated these data, in fact, because you can see this is overall survival, a Kaplan-Meier survival function showing that there is no any difference between group A and B, but this is overall survival for all groups. So it's a heterogeneous data. It has large amount of statistical bias, so it's not considered to be sensitive. So in conclusion, there is no high level of evidence saying that transhiatal or transthoracic approach, which one is better. So majority of the literature has criteria to develop which type of approach is better than the others. So the decision regarding surgical technique is mostly based on the experience of the surgeon and the hospital morbidities and the stage of the disease. In our series, there is no statistical significant difference between these groups. The baseline in the terms of demographics or tumor characteristics, except COPD, was found to be higher among group B, while this higher number of COPD in patients in the transhiatal group based on the fact that the transthoracic approach is associated with higher postoperative cardiorespiratory compromisation, and that's why the selecting criteria is considered to be a statistical bias as well. So despite our statistical finding, during our work, we observed that the transhiatal procedure is less time-consuming with care and follow-up less, stressing the involved teams, and most of the patients were more satisfied and had less pain in comparison to transthoracic approach. Despite our study has relatively small size and the patient group and non-randomized one. In fact, we have criteria, so this is not considered to be. This is one of the limitations and weak points for our study. The duration of the follow-up is relatively acceptable because we follow these patients at least for 4 years until so we estimated overall disease-free survival. Larger size studies are definitely better to be included for having better conclusion regarding these complex types of surgeries and complex type of cancers. Thank you very much.
Later.
Sorry?
Take your place, please. Later we discuss the subjects. After all, the complete this. Thank you very much.
The second presenter will be Professor Dr. Adnan. Dr. Adnan is a professor of pediatric gastroenterology in Suleimani University and digestive hospital disease. So now, Dr. Adnan, please present your topic about the eosinophilic esophagitis.
Good morning, dear attendants. Today we are going to talk about an emerging disease among pediatric age group. These are the learning objectives. We try to comprehend the definition of EOE, the clinical presentations, diagnostic approach, and the management according to the guidelines. EOE is a chronic immune-mediated inflammatory condition characterized by esophageal dysfunction and eosinophil predominant inflammation of the esophageal mucosa, diagnosed after exclusion of other cause of esophageal eosinophilia. The incidence among pediatric age group is around 5 cases per 100,000 population, and the prevalence around 20 cases per 100,000. EOE is diagnosed in around 4 to 5% of patients undergoing upper endoscopies, and if the indications were dysphagia, the percent would be much higher. It's common in males and has a strong association with concomitant atopic conditions such as asthma, eczema, rhinitis, and food allergies. The pathogenesis is not entirely understood yet. It's unlikely that it's an IgE-mediated condition. Food allergens trigger EOE, stimulating an dysregulated immune cells through an impaired esophageal epithelial barrier. The presentation vary according to the age of presentation. Young children usually present with non-specific symptoms: vomiting, feeding difficulties, abdominal pain, failure to gain weight, and they fail to develop normal eating pattern, shifting from liquids, semi-liquids, and then to harder food. They don't advance, they stick to the liquid parts, and the family is obliged to soften the food so that they can perform the swallowing. Food aversions, and as we say, sometimes failure to thrive. However, adolescents can present just like adults. They have the classical symptoms of dysphagia, odinophagia, and food impaction. The patients usually adapt themselves to that pathology, and they develop coping mechanism to compensate for their symptoms. They eat slowly, they chew excessively, taking small bites or cutting the foods into small pieces, lubricating the food with different sauces, drinking fluid after most of the bites, and avoiding textured food. For the diagnosis, upper endoscopy is considered as the gold standard, along with biopsies. These are the common endoscopic features we see. They have exudates, tracheization or ringing, along with linear following. Since the esophagus may appear normal most of the times, then we need to take biopsies even if the esophagus looks normal. It's different from that of GERD. We need biopsies from different levels from the esophagus. Usually we take from 3 levels: lower esophagus, mid, and upper esophagus. This is the ERFIS, the endoscopic reference score. We need it especially on the first session. We need to score because this is essential then for the follow-up. You know the improvement after improvement of this score. The biopsy should contain more than 15 eosinophils per hypower field. There are other associated pathological features like basal cell hyperplasia, papilla elongation, microabscesses, laminar fibrosis. This is essential to differentiate it from especially gastroesophageal reflux disease. Other forms of investigations are not necessary unless you think there is a stricture or there is a narrow esophagus. Then you might need imaging studies. This is the PES, the pediatric EOE severity score. It is informative regarding the frequency and severity of symptoms in children, and it also reflects the improvement with management of this disease. This is an elaborative study done by Martin et al. In 2015. It shows that the pediatric eosinophilic esophagitis symptom score identifies not only the clinical pattern of the disease, but also the histologic and molecular correlates of the disease. They included children 12 to 18 years and reported the symptoms via the mother report or parents report. At the same time, they took biopsies to quantify the level of eosinophils, to perform immunohistochemical staining, and mast cells. The results showed that the domains, there were 4 domains in this study, to specific parent report system: dysphagia, GERD, nausea, vomiting, and pain, were all associated strongly with the symptomatology, but the dysphagia domain was mainly related to the histopathological changes you see. And markers of esophageal activity were significantly associated along with dysphagia. These are the features and the 4 domains. As you see, the main related symptoms to the dysphagia domain. And these were the genes that were tested, and the genes for mast cells were most related with the activity of the disease. How to treat these patients? We target 3 main points. First, symptom activity, endoscopic activity, and histological activity of the disease. The 3 targets should go along with each other so that we can have better results with these patients. Dietary therapy, dietary modification is effective in a significant number of patients. There are 3 modalities of dietary intervention: the empiric elimination diet. In this one, we have 6-item food restriction, or 4-item, or 2-item, or 1 item. okay? Empirically, we restrict 6 items: cow milk, wheat, eggs, legumes, peanuts, and fish food, seafood. The elemental diet, as we use it in inflammatory bowel disease, this regime, all foods are replaced with an elemental amino acid diet-based formula, or targeted elimination according to the IgE testing for food allergy. This is not much clinically correlated because you have false positive and false negative results with that test. Pharmacological therapy, of course, PPI is the cornerstone of treatment in this disease. In addition to acid suppression, it has anti-inflammatory properties. Topical steroids, including budesonide, fluticasone, and other pharmacological options, and both are effective in improving the symptoms and histology with AOE. Many different administration modalities have been used, but the best is the viscous budesonide or fluticasone viscous. We don't have these preparations. We use the inhaled. We use the inhaled and effervescent tablets. Endoscopic therapy is limited to retrieve food impaction or bypass it, or to dilate and stricture the esophagus. This is the new regime in the treatment. It's a bit tough. We step up, starting with 2 food elimination for 6 weeks, so then we do OGDs. If the eosinophil count is more than 15 yet, we increase to 4 items. 6 weeks later, we do OGD. If it is more than 15 yet, then you increase to 6 items. When the symptoms are improving, then you step down. With each item, you do OGD. I think this is a bit much aggressive modality of management. Many drugs have been tried: leukotrienes, biologic agents, immunomodulators, and chromoglycate. They all had very limited success in these patients. A new drug is working for, let us say, difficult cases, tough cases, not responding to the traditional treatment, and that is dupilumab. This drug is an interleukin-4 receptor alpha antibody. There has been few reports about pediatric patients and adult patients recently, and it is a promising drug. How long we maintain the treatment and the food restriction, yet it is not clear. There is no consensus or a guideline that limit your restriction. We have been restricting patients for 6 months, then doing OGDs, and then for 1 year, and the relapse rate is very high. And you can resume management of these patients until a clear-cut consensus or guideline is in action. EOE is an emerging antigen-mediated inflammatory disease of unknown etiology. It's a multifactorial disease typically characterized by type 2 inflammatory response. The clinical presentations depends on the age and mainly includes food refusal, vomiting, abdominal or chest pain, dysphagia, and food impaction. Endoscopy is the gold standard to diagnose EOE, and the goal of therapy is to achieve clinical and histological remission, not only clinical and histological remission to prevent esophageal fibrosis. Cornerstones of therapy are PPI, topical steroid, and elimination diet. Thank you for listening.
Thank you, Dr. Adnan. Now the third speaker is Dr. Samar Saad. Please come to the stage to present her topic. It's about unusual endoscopic finding in Kirkuk GIT Center. Dr. Samar, she is consultant gastroenterologist in Azadi Hospital and assistant professor in Kirkuk Medical School. Please, Doctora, your time is 10 minutes. تخوا ئەوەی دوای ئەو دکتۆر ئاڵتون بە حازری کەن بۆی ئاو سەوزەیە ئەو شتێ بۆ حازرکەن خیارە بیکەن.
Good morning for all. Thanks, Mr. Chairman, Co-Chairman, and for the committee to allow me to share you two cases of unusual endoscopic finding, at least for me, presented to the GIT Center in Kirkuk. The first case is a 22-year-old man with history of crystal addicts or abuse. For the last 3 years, he claims that he stopped taking crystal for the last 3 months, started to develop chronic diarrhea with the blood. On the examination, he is cachexic, irritable, underweight. On the examination, the finding was just scatter circles in the chest examination. We plan to arrange for the endoscopic colonoscopy, and the inflammatory marker was high regarding the CRP and the fecal calprotectin. And the endoscopic finding was a multiple skip lesion in the form of large, huge ulcers, which is semicircular transverse with indurated margin. And there is a destruction of ileocecal junction with multiple pseudopolyp. Biopsy was taken, and during waiting for the result of biopsy, we arranged for the CT contrast of the abdomen, and the result was distal ileum with ileocecal valve and right-sided proximal colon diffuse wall thickening with mesenteric inflammation and multiple lymph nodes. The picture was support the diagnosis of TB. As you see, there is a right-sided or ileocecal and right-sided colon wall thickness, which is extends to the mid-transverse. So we return to the other diagnosis, and we arrange for chest X-ray and the CT, and the finding was multiple scattered subcentrometric pulmonary nodule. Picture suggests of active TB pattern. We are supported by Dr. Kermanj Ismail. He is a consultant radiologist. And we retrograde also the investigations, and we send for sputum for the PCR and expert gene, and it is positive for acid fast bacilli. The biopsy is reached with multinucleated giant cells with caseating necrosis, which is called with caseating granuloma, supported by Dr. Zana Tahsin. He's the histopathologist. So whether this case is TB or Crohn's, regarding the endoscopic finding, the picture is support TB because it is a semicircular, transverse and not longitudinal. There is no couplestone appearance. There is no perianal lesion. So it mostly goes with the TB colon rather than Crohn's regarding the endoscopic finding. So we start anti-TB. The patient is very well, gaining weight, getting family support, psychological support regarding his addiction, and with a close follow-up. For me, it is unexpected because I was thinking with the side effect of the crystal intake, which is the methamphetamine, which can cause mesenteric ischemia or infarction by different mechanisms, including necrotizing vasculitis, cardiovascular shock, sympathetic omantic vasospasm, and supplanting vasoconstriction. It's remained unclear how important each of these mechanisms contributed to induce bowel ischemia. The other case, it is a 53-year-old patient referred from other governorate with history of repeated vomiting and weight loss for the last 5 months, preceding by open surgery regarding cholecystectomy. And then the patient started to develop repeated vomiting with no response to any medication. So on the examination, she was underweight, dehydrated, there is a fullness in the upper part of the abdomen. So we sent firstly for an ultrasound which showed distended stomach with food particles. So on the base that they suspect that there is a gastric outlet obstruction, so arrange for prolonged fasting, and we're planning for the upper endoscopy. The finding is still there is a food particles on the stomach which is distended and deformed of the pylorus. The scope cannot be reached to the second part of the duodenum only because of the impaction of the food particles. So we arrange for prolonged fasting and insertion of a nasogastric tube for gastric wash. During this period, we planning for CT contrast on the base that this is maybe a DJ junction tumor that cannot be reached by the endoscopy. This is the first endoscopy. And I get a phone from our radiologist. He said, I diagnosed a PAC which is impacted, a surgical PAC which is impacted in the duodenum. As you see, this is on the duodenum, between the second and the third part of the duodenum. And then we arrange for prolonged fasting and prepare the other endoscopy. This is other part which is radio-opaque. Of course, we still depend on the plain X-ray, and also there is a radio-opaque foreign body. And by the endoscopy, there is a PAC on the duodenum between the second and the third part. So we try to extract this by a rat tooth forceps and snare biopsy. It was, in fact, it was stuck in the duodenum. And this is the surgical PAC which impacted in the duodenum for the 5 months, which is even take the shape of the duodenum. This is the PAC. The patient developed rapid improvement, and she was asymptomatic on the second day with no vomiting. So the source of this PAC is still mysterious, whether this is part of injustice of this food particle due psychological upset of the patient, for example. But we assess the patient. She was stable, apart from she has 2 crippled child. Maybe this is a technical error by a staff in the surgical ward. They said they maybe use this PAC for the fixation of endotracheal tube.
عفوا دكتورة سمر 2 minutes remaining.
Yes, it is unlikely to be missed PAC during the surgery, because after the extraction of the PAC, there is a nearly normal endoscopic finding of the duodenum. There is no ulceration or site of perforation. So if it is ingested, the history of ingested foreign body is commonly encountered in the child, although rarely seen in adults. Rate mortality and morbidity among adults is much higher. The size, type, and the structure of the foreign body is give a plan for the intervention. CT scan is a good tool for the diagnosis, and it's better to use without oral contrast because you will miss some of the foreign body, especially those who are not radio-opaque. The sensitivity of the CT scan and the specificity is 94%. Oral contrast is better to be avoided. So do not be hurry to send for a surgeon unless he is in a good mood. And this is our groups in the Kirkuk GIT Center, and thank you.
The next speaker will be Dr. Altoon Muhammad Saleh. She talked about the rare cause of the diarrhea in transplant patient. Dr. Altoon is a gastroenterologist and a lecturer at the Hawler Medical University. Please, Dr. Altoon.
دكتور عبد الله دواء أبو يحاسركن.
Welcome to all. I'm so happy to be here in 4th KDD, and I would like to present a rare cause of chronic diarrhea in a patient with kidney transplant. I saw the case at September 2021. A 61-year-old man who was a case of kidney transplant was referred for endoscopy upper and lower because of chronic diarrhea. Endoscopy was done. The finding was diffuse mucosal erythema, congestion, and erosions of the stomach and duodenum. Biopsy were taken from both, and colonoscopy revealed multiple small 3 to 8 millimeter ulcers throughout the rectum and colon with mucosal congestion and erosions. Normal terminal ileum. Biopsy were taken. So what could be the differential diagnosis for this case? Transplant and chronic diarrhea. Could it be infectious? If infection, which type? And non-infectious cause could be immunosuppressive related or other drugs or other causes that we can see here, a list of causes and different etiologies for chronic diarrhea. We discussed the case with our pathologist and we asked him to update us as soon as possible since the patient was looking tired and emaciated. The histopathology returned back to be like this. It's showing duodenal biopsy. Here, normal Brunner glands, and here there is abnormality. There was a parasite, intraluminal parasite, in all samples, even in the ileum, which looked normal by endoscopy. It was strongyloidosis hyperinfection syndrome. We discussed the case by nephrologist. The case was referred to GI team. Since he was emaciated, anorectic, he was admitted. In the review of the case, he was a 61-year-old man from Basra, oil company worker. He had history of 2-time transplant. The first time at 91, the donor was his dad. And the second time, just 6 months before presentation. It means at March 21, he was taking myfortic, Prograf, and prednisolone. He was hypertensive, dyslipidemic, and diabetes, which was well controlled by dieting. Regarding family history and social history, it was unremarkable. No family history of any chronic disease or infection. The patient presentation was just 1 month after the second transplant, gradually progressive watery diarrhea, which was small amount, day and night, up to 10, loose bowel motion per 24 hours, with loss of appetite, loss of weight, up to 16 kg, that worsened in the last months before endoscopy. He denied any fever and chest symptoms or sweating. On examination, he was looking tired, cachectic, pale, with fine tremor. Abdomen was soft, chest and heart were clear, and there was no leg edema. Blood pressure was okay, but he was tachycardic. BMI was 17.5. We ordered a complete panel of investigation, including TAC level, which was elevated, and we modified the immunosuppressive. He was anemic, normocytic, normochromic, white cell. There was lymphopenia, no eosinophilia on the blood film. There was evidence of hypoalbuminemia, hypomagnesemia, hyponatremia, elevated ferritin as an acute phase reactant, while ESR, CRP, procalcitonin, everything were normal with normal kidney function, fortunately, and normal liver lipids with a good controlled HbA1c. We decided to admit the patient and we started PPI, meropenem together with antiparasitic agent ivermectin in the dose of 200 microgram per kg, which was 12 milligram per day. After, and albumin, since it was low. After the days of admission, he was feeling better and he could discharge the patient. On follow-up, after 3 weeks, there was a good and dramatic response. The patient gained 11 kg per 3 weeks, and he feels much better, less fatigue, a good appetite. And the bowel motion was reduced from 10 to 3 to 4 motion per 24 hours. 2 months later, he was, we can say, completely good, another 5 kg weight gain, and lab test was doing well. The calprotectin, which was more than 2,000, now it was down to 165. Type level was slightly low. We increased the type dose, calorimetric dose, and everything was okay. We continued ivermectin 12 milligram twice per week for up to 2 months for the case. As soon was okay, no parasite. I forgot to tell in the first visit when we saw the patient and we know the diagnosis, we said for a stool exam, a simple test which revealed the parasite. Unfortunately, I lost the video of the stool exam. However, it was very good and patient fortunately was totally normal after 6 months. Just to have some idea about tuberculosis, hyperinfection syndrome, which is a pneumococcal infection. It is a devastating disease, mortality rate up to 50% in immunocompromised patients. It results from reactivation of latent infection, transplantation. It is the most common cause. Sometimes it could be related to donor transmission. As we mentioned, it may be activate, clinically may present is cardiopulmonary symptom or GI manifestation or sometimes disseminated disease that can lead to death. Unfortunately, patient improve. Thank you.
Our next speaker is Dr. Abdullah Zuhair Al-Yusbaki. Please come to present your topic. It's about refractory GERD. Dr. Abdullah is gastroenterologist, is lecturer in College of Medicine, Mosul University. Please, Dr. Abdullah, try to finish it less than 10 minutes.
Alaikum. It is my pleasure and honor to be here with my teachers, my sister and brother, my lovely city, Suri. I will speak about refractory GERD. This is my lecture sponsored by Hikma Drug Company. First of all, I will start with the definition of refractory GERD. It is partial or lack of response to PPI despite of twice daily PPI. In such condition, we consider that the patient had refractory or failed response to PPI. Even some consider one tablet, 14 PPI, with no response to even one tablet is considered as refractory GERD. The incidence of refractory GERD is around 10 to 40% of patients with GERD are failed to respond to PPI. Most of such patients with refractory GERD
have either non-erosive reflux, NERD, or functional heartburn. Functional heartburn and reflux acid hypersensitivity is considered as the most common cause of failure to respond to PPI. There is psychological comorbidities under the etiology of functional heartburn. The other cause of refractory GERD is insufficient acid suppression, because the PPI sometimes may be related to the timing of taking and adherence to PPI intake, as well as there is difference in the PPI metabolism. As you know, not all PPI are metabolized by the liver, but by different cytochrome that present in the liver. Sometimes other cause of refractory PPI is due to residual acid reflux and weakly acidic or alkaline reflux, what is called non-acidic reflux. How we are, what are the other etiology that may be misdiagnosed as refractory GERD, like achalasia, eosinophilic esophagitis, infectious esophagitis, pill-induced esophagitis, gastroparesis, and rarely esophageal stricture or cancer, as well as rumination syndrome. All these might mimic the presentation of GERD and can be considered as refractory GERD. As Dr. Adnan mentioned, one of the features of eosinophilic esophagitis that presented as GERD. How we are going to do management? First, we should rule out the presence of alarming symptoms. If the patient had alarming symptoms, we should go immediately for EGD. As well as if the patient had refractory, again, if the patient who have refractory GERD, if the endoscopy is not done previously, we should go immediately for upper endoscopy. If the patient have no alarming symptoms, we should start with general measures like lifestyle modification, weight loss. We should concentrate about dietary modification and compliance with PPI intake, timing and compliance with PPI intake. Optimized PPI therapy, about the dose, doubling the dose of PPI, morning, before breakfast, before dinner, as well as switching to another or more potent PPI. Here, the importance of the diagnostic tools in refractory GERD. The most important is the esophageal pH monitoring, 24-hour pH monitoring, in addition, plus minus the presence of impedance. To a lesser extent, esophageal manometry. But the most important and crucial test that can be done in such situation is the 24-hour pH monitoring of the esophagus. And this is the instrument they use to monitor 24-hour pH, and this manometry. Patient, if the impedance test is not available or not done, we can add with PPI. We can use baclofen in addition to PPI. It will inhibit the transient lower esophageal relaxation, sphincter relaxation, as well as we can add bedtime H2 receptor blocker, famotidine. But famotidine should be not used for a long time because we'll end with tachyphylaxis and lost the response. As well as if there is element of esophageal hypersensitivity or reflux hypersensitivity, I can add some pain modulator like amitriptyline, nortriptyline, and so on. If the patient with impedance test, if there's residual acid reflux, we can add also, in addition to PPI, alginate, H2 receptor blocker, and reflux inhibitor like baclofen. If there is suspicion of bile acid reflux, we can add cholestyramine and sucralfate. Just 2 or 3 slides about one of the new PPI. It is available in our market, what is called the Dixilent. It is a brand of Hikma. It is isomeprazole, introduced, take FDA approval in January 2009. It is characterized by dual delayed release formulation, that 25% of the tablet is released immediately after intake, and about 75% of the tablet it take longer release. So it has dual delayed release properties. This will differentiate it or give a positive mark over the other types of PPI. It is available as 30 milligram and 60 milligram. So most of the PPI doesn't give us 24-hour acid suppression, but with Dixilent, the situation is much better. So we'll avoid the breakthrough symptoms, especially at night, and we can take it, just give it once daily, no need to take it twice daily, and no need to stuck with the breakfast. We can take it even before or after any meal. There's also another point in favor of Dixilent. So it has extended release of action, as I mentioned, with no relation to food intake. Just one slide. This also the granules, the pellet that's present inside the tablet, and this is the comparison of Dixilent with other PPI. It has better acid suppression. So it has immediate and delay release of the pellet, and this is the features of Dixilent. And thank you. This is my city, Mosul, College of Medicine, and my lovely city, Suli. Thank you.
Now we invite Dr. Shang to present her talk about the gastric companion.
كاكا أما بو كيه معنا أبو إذا كان البرزنتر كان
سلونا شو فريق كين
فلانا كين كين هذا بعد people يبينش ده people استو طايقة لايف معنا.
Okay, just you have 7 minutes.
اليوم هليت عيبتي
Okay. Hello again. It's my pleasure to share with you the project of the Gastric Companion. Gastric Companion is a project that mainly focusing on the pharmacological treatment or on the products that are directly indicated to the GIT problem or the products that have side effects or heavy on the GIT. It is a group of the product and mainly sponsored by the Green IVY company. Let me return back to the scientific part. Today I will discuss the H. pylori and the post-transition metal bismuth, or more specifically, bismuth subsalicylate in the H. pylori. Actually, it seems that the gram-negative flagellated bacteria is asked for the residency in the stomach. And due to its adaptability, it's accepted. And it is just acting like safe at the first until it activated and making a symptoms. And as a result, this is the incidence of H. pylori globally, regardless to the developed or developing country. Estimated global numbers is more than 50% of the population is affected by H. pylori. And for the developing country, unfortunately, it is 90%. Actually, as we have this huge number, we couldn't send everyone to the investigation. We couldn't screen everyone. But as a study done in the USA in the conference, it shared some specific cases that we have to send them to the screening, even if they don't have symptoms. The most common one, those who are on the chronic NSAID or unexplained or we could say dyspepsia, current and history of PUD, or we have some specific population that they have risk of the gastric cancer, or the people that are living with the people in the same house that they have active H. pylori. Let's work again. Okay. Simply, it is an infectious disease. So, when it's an infectious disease, it means the goal of the treatment or the coverage, it should be more than 90%. And the goal of the treatment or the expectation of the treatment should be more than 95%. But unfortunately, we all know that the treatment of the H. pylori nowadays is fail. The main cause of the failure of the treatment is antimicrobial, patient-related, and adherence. Antimicrobial resistance is one of the emergencies that are occurring globally. Nowadays, the levofloxacin, that was the hope of the previous years, it's going to uprising the resistance. Metronidazole is the same case. And vice versa, if we focus on the amoxicillin, the resistance is just dropping for this one. For that, the antibiotic alone nowadays couldn't cover the eradication of the H. pylori. The second one is therapy issues, duration, the time of taking, and sometimes the BMI of patient also, and the pack of combination of the therapies. Maybe they are not directly right dose for each patient, and for sure patient adherence. Unfortunately, even the healthcare professional, they are not following the exact taking of the antibiotic. So what could help us? I need to focus on the bismuth, a metal that is combined with the subsalicylate. We could mention as a salt when it is combined. Actually, bismuth is FDA approved in 1932 for relieving of the 5 symptoms of the GIT. It is classified as antidiarrheal and antidyspepsia. But nowadays, it is, as it is effect on the antibiotic, on the bacteria, it is bactericidal by different mechanism of action. It's one of the choice of the treatment. Actually, it is not a substitution. It is an addition to the protocol that you're already used with your patient. Simply, bismuth, how it's acting. Bismuth is just going to the cell of the bacteria. It's making a ballooning between the cell and the preplasmic membrane until rupturing the bacteria. This is the first one. The second one, as it is a cation, is binded to the enzymes of the bacteria, and it inhibiting the process of adapting of the H. pylori. As a result of this mechanism of action, the new guidelines. Toronto, Maastricht, Florence, and ACG, they recommended quad triple therapy bismuth-based as a first-line therapy for eradication of H. pylori. Actually, it came from some studies. As we mentioned, there is strains that are resistant to the most of the antibiotic. Actually, this is demonstrated the 3 different groups. The first one is the strain resistance to the clarithromycin, this one to the metronidazole, and that dual resistant to the clarithromycin and metronidazole. If you check for all the group, when you're adding the bismuth, you saw the difference of the efficacy of the treatment for these patients. Plus, this is, just 1 minute, let me to finish. This is a comparison between the 14 days triple therapy with the 10-day quadruple bismuth-based therapy. In the initiated and the end of the study, you could show that there's a huge difference when you're adding only bismuth to your treatment. I just need to focus on the dose of the bismuth. In the case of H. pylori, it's kind of different from diarrhea and dyspepsia. Actually, it is available in the tablet and suspension dosage form. Each dose of the tablet is 2 tablets, and for the suspension, it's 13 ml suspension. It is taken 1 by 4 for the patient the age more than 12 years of old, and below the 12 is not recommended due to the subsalcinate. It's up to you and your experience with the lower age of the 12 of age, and there is no interaction with the food or for bismuth, so anytime patient could take it.
Okay, Doctor, thank you.
Thanks, and happy Friday for all of you. As you know, the only option better than treatment is prevention. Let us prevent the future unusual events.
Thank you, Dr. Shank. We apologize to the presenters, respected presenters and audience. We cannot take any question or any intervention because they told us there will be online. Just now they start to have online from Anwar Sheikh Hospital. Although they presented very interesting subjects, you may discuss with them after that during the lunch or later on. We apologize and thank you for your attention.
Rapid comments on the presentation. Away character aram zor interesting bo hazma kert لسر hypokalemia ketose majali boya aya awa paraneoplastic syndrome effect maybe, or the patient was for a long period dysphagic, nutritional, or the patient you mentioned they are hypertensive and heart disease, maybe on diuretic. So there are several explanations for them. But in such case, hypokalemia, as you mentioned, is very significant. For Dr. Adnan, thank you very much. Yes, we didn't see cases because you see the pediatric, but in adult we saw cases. The recommendation is that any patient, young patient with dysphagia or food impaction, think of esophageal, eosinophilic esophagitis, and when we did endoscopy emergency to get the bolus, please take biopsy. And thank you for his presentation. Away, Dr. Samar, very interesting. Really, we present the second case you present in Suleimani because he was already, I think, passed here, but he didn't accept to remain in hospital. And this is a condition called gozoma, when the gauze missed intraperitoneally, and by making pressure, making fistula will enter the small intestine. This is the most common explanation rather than swallowing such big pack, which is less likely to be. That's time. Okay, thank you very much. Later we will discuss.
Sorry. Good morning, my colleagues, my seniors, my teachers. I am very glad to have this live endoscopic procedure session, and we know the most amazing and exciting sessions in the conferences, international conferences, is this live session. Different advanced interventional procedures will be issued in this session, and I am glad to see again my faithful sister, Dr. Nawal Khalidi. She was with Dr. Taha Al-Karbuli. I am not sure he is there or not. They were the first two candidates joined the Iraqi board for gastroenterology and subspecialty program. At that time, my teacher, my big brother, Dr. Makki, was the head of the gastroenterology center, and I was his deputy. And Dr. Omar Hamagalib also joined us to have a share in this live online transmission of the procedures. We know the achievements in interventional endoscopy in the last 2 decades were greatly improved, both in upper procedures and in lower procedures. And the 2 most advanced one in the last 2 decades are doing POEM, initially adopted for the esophageal achalasia, and the ESD for intramucosal lesions, a modified EMR. So the guests and the professors coming from outside of our country have I don't know how many number of the patients have these procedures online from the Anwar Sheikh Hospital.
أكو مشكلة بالنقل شباب؟ ماكو نقل.
Dr. Nawal, if you have a few talk before the session, I am glad.
بسم الله الرحمن الرحيم. رحب بالجميع وإن شاء الله it will be a very fruitful workshop, maybe the core of the meeting. The most recent advanced approach in gastroenterology is the third space. I consider it as a revolution, and I hope we will have a very good cases after a while. بس أعتقد طالما نقل ماكو فإذا أكو discussion على الكيسات، لأن أعتقد أكو أحد يريد يعلق على الكيسات اللي تقدمت قبل قليل. دكتورة سمر يمكن تتعلقين على الكيس مال الجوزة؟
Against this, that the patient must be developed and types of perforation, and this cannot be wait for 5 months. Usually the sign of perforation will be tolerated for up to 10 days, as mentioned in the literature. But the patient tolerate this for the last 5 months, and endoscopy after the extraction of the foreign body, the mucosa was entirely normal, and I think it will be against the penetrated lesion, as I think.
Actually, I had colonic gauze, but as you mentioned, at that time it is impossible to retrieve because it's through the mucosa and the mucosa surrounding it abnormal. Though the 2 stories are very difficult, actually.
But the patient mentions that I start to develop dysphagia after the 2 days after the operation. And one of the surgeons, he comments that this is maybe a misgauze that used for the fixation of endotracheal tube, and maybe there is a local injury, they impact and they missed maybe this.
Sorry, Dr. Samar. Which type of operation had been done before?
Cholecystectomy.
Open cholecystectomy. It is possible because we faced a case of mist pack erosing the duodenum. I think Dr. Ta, if he is here, diagnosed the case missed for 6 months with erosion of the wall of the duodenum by chronic inflammatory process. It is not unusual to miss a pack to entering the small or large valve of even the duodenum by inflammatory process and erosion, making a fistula, and then the fistula will heal spontaneously.
أعتقد راح
Yes, I
اللي
think,
بدل-
sorry, I think the Dr. Iwa is
دكتور هيوا
starting to connect with
تسمعونا؟
us.
دكتور هيوا تسمعونا؟ لأن إحنا ما نسمعكم. هاي من بده يحكي؟
Do you hear us, Dr. Hiwa, Dr. Hero? Yeah. When do you start the interventions?
شباب النقل بمشكلة منا كل ومنا أنا.
No sound. تاك دكتور جان باخري شو بين يك دقيقة بزاني connection بيا connection أجا connection أبو بس تشاو there's time please.
إيه.
connect بو.
الو يا جوسيا اي صوت
اخر ناس انا سألي شو
اي بلا عبد الفتاح كاكا لقى عبد الفتاح كراكسن بوكا بلا عبد الفتاح في بورجر زانم
عبد الفتاح يقول
لا دي مودريتر كان لسه ستيج جنبي بلا عبد الفتاح باب السرخات
محتاجها نفس الليفل كلها ممتاز.
Dr. Hiwa, do you see us? Can you hear us?
لا ما ادري شيء ابزان لشنو موبايلك محمد جان
لا اسماعيل صح؟ انت اسماعيل محمد
No, he is not responding. Dr. Hero, Dr. Hiwa.
ولا مودريتر كان لين
We are waiting for you.
هو تقريبا ان هي على واحد بس هو الهواء طلع بس
يا جماعه ايش هو؟
بدها تخابرهم؟ إيه شوف.
بسم الله الرحمن الرحيم. Hello everybody, good morning. We are very glad to present to you our next session, which is live demonstration from Anwar Sheikh High Quality Hospital. Today we will be very glad to present to you many interesting cases, including third space endoscopy, POEM, DPOM, endoscopic submucosal dissection, and many cases of endoscopic ultrasound, including EOS FNB, inshallah. So we will start our first case from the room number 1. Now Dr. Sivan Hussein, she will present to you the first case.
Dear attendees, the first case of today is a 46-year-old man with 6-year history of progressive dysphagia for both solid and liquid, associated with progressive weight loss and chronic cough, negative past medical history and past surgical history. There is only family history of Down syndrome. During workup, the OGD showed a hugely dilated esophagus with food residue, and the scope passed with resistance through the GE junction. And CT scan, contrast-enhanced CT scans showed dilated esophagus with air fluid level and smooth tapering of the GE junction, picture typical of achalasia.
Case of dysphagia, we know this procedure, what's called POEM, peroral endoscopic myotomy, is an equivalent to the surgical Heller myotomy, being reported the first procedure in 2008, ideally for the achalasia of the cardia, but later on expanded to other GIT areas. For example, in gastroparesis, the same procedure, myotomy of the pyloric sphincter, and even in adult Hirschsprung disease, perrectal myotomy can be useful. So this is a dilated esophagus, Dr. Nawal.
Yeah.
Dr. Aras?
Yeah.
You hear us?
Yeah.
So the first case I want to present will be the procedure case of achalasia, as you hear from the history.
Yes.
Will be presented by Ustad Dr. Ahmed Madkour. He will be operator and moderator, commenter Dr. Amr Al-Fouli, and I will be his assistant, inshallah.
Yes.
Assalamu alaikum.
Wa alaikum assalam.
So you can hear me well, and you can see endoscopic image.
Yes, we can see you.
Yes,
and
okay.
We can see the field very clear.
Okay, so it's my great pleasure to be in Sulaimaniyah and in your well-organized conference, and I am inspired by the infrastructures and the professional team here in the room with me, Dr. Amr Al-Fouli, my brother and friend and my teammate, Dr. Hiwa. He is supporting us to do this procedure. Yes, no, you're an expert, and our anesthesia team, he is very professional. He do it in no time, and we are supported by our friends here from Iraq, Dr. Marwan and Dr. Muhammad and Dr. Hero for sure. So and Dr. Taha, you can see him. Yes, he's here. So as you can hear, it's a case of dilated esophagus and achalasia type 1. Before the life, we go and clean the esophagus, and this is the mandatory step. We already have a prolonged fasting, so we don't have a lot of remnant fluid here. After we do cleaning of the esophagus, we check the mucosa, and here you can see the mucosa is a little bit thick, and we try to pass the cardia. We should do this carefully and use some water pressure, not to cause mucosal injury while passing the cardia. It's a tight, and then we go to the stomach. This is the typical picture of achalasia, but it's not always like this. Sometimes we see some cases with not so tight cardia, but manometry can diagnose. We should do retroflexion here in all cases, so we can rule out any pseudo-achalasia or any local cause which cause this tight strictures of margin. So we can see nothing here in the cardia. Then we go back. We use Olympus X1 scope, and we use Olympus electrosurgical unit. It's mandatory to use CO2. So we have CO2, we don't work with air, and we'll use Olympus TTG9. Where to start, how to do the steps, this will be our aim now. So we go back slowly. Here we can see the Z line. Z line almost at 40 centimeters. So we should go for a standard foil procedure. We should go for 10 centimeters above the cardia. If we're dealing with type 3 achalasia, we may move for around 20 or 22 centimeters. With type 1, we can do a shorter tunnel. So here we will move back, try to be straight. You can see it's dilated, so we flip down. Actually here, it's around 10 centimeters above the cardia. Here is the spine. You can see
Dr. Madkour,
we can go to the left.
Can you hear us, Dr. Madkour?
I think this is a nice position to start our injection.
Dr. Madkour,
if anyone wants to ask any questions, we can communicate. And we need mic for Dr. Amr so he can help us and he can. So every step, every single step is important because it helps the other steps in the procedure. So now the first step is the injection. We have a 23 gauge injection needed. Here is the direction, here is down. One important tip, if I push the needle like this, you can see it go far away. I don't control well. So what I do this in any injection in the esophagus actually. I give little bit down, like this, so I have the mucosa in front of me. So when I have a needle out, it's better to inject. Then I ask Dr. Hiwa to have the needle out.
Dr. Amr, sorry, how many centimeters away from the gastroesophageal junction you will inject? Approximately?
10 centimeters. 10 centimeters.
10 centimeters. Anteriorly or
posterior?
Anteriorly or posteriorly?
Take the needle up in. Posterior, here. If we inject some water here, you can see the pool is down. So it's posterior. We should identify the spine. The spine is here.
So you prefer posterior approach always?
Yes, I always prefer posterior approach. But we can do anterior posterior. But actually, I do all my cases in posterior approach. So if we come here and we will start our injection.
For the audience, the injecting material is methylene blue or inticarmine or saline. What do you use?
Continue injection. We will use saline, continue injection.
Yeah. And the coloring agent?
Continue injection. Yes, we inject the saline with methylene blue. We didn't use adrenaline. In point, in ESG, we use adrenaline. So this is a nice lifting, this is a nice plate we expect. We will have a difficulty in this case because it's dilated. Continue more pipe. Because it's dilated, so that the scope may loop inside the esophagus while we try to enter to the tunnel. We should expect this needle in, and we have a plan how to deal with.
So, Dr. Amr, this is the first stage of creation of a mucosal bleb.
Yes, yes. We should do this fast after the injection, not to let the fluid absorb it, especially in these patients with dilated esophagus. And here we expect a lot of new vascularization in some mucosa. We expect some fibrosis. So we may have some difficulties, but we will try to do our best to help our patient. The second step is to do, you can see here we are actually looping. If we try to push, we loop inside the esophagus. This is not the normal, but this is what we see in patients with dilated esophagus. Can we ask the needle out?
This is a special type of needle.
What type of needle you use? The triangle or the rounded?
It's a TTG9. Here I have a problem. It's hugely dilated, so I have to give down while cutting. So what I think about to do incision in a different way like this, or to choose another point for injection, but I think we can do this way. I just change the strategy to deal with this dilatation. So after I do the first incision using the blended current, I use a spray to add now, but I'm not sure if, yes, now, it's working now. I use a spray to add to the edges, like to do a trimming of the edge. If it didn't work well, I can use again the cutting current. I should have a nice dilatation here before I try to go inside. So I cut the muscularis mucosa. The needle in. Inject, please. Okay. After this, I try to use my cap to go inside. Here, as I say, I expect some difficulties because of the dilatation and the expected looping of the scope, but we will try to deal with. Now we work like as if we are working in anterior because this is the only position suitable. So I will dilate the apex little bit before I try to go. It's wise to do this, not just to try to push the scope. If you did, you will only dilate the entry and will not go inside. Inject through here.
The incision is transverse, right?
No,
it's longitudinal.
Longitudinal, yes. And how?
Yes, longitudinal usually is the standard, needle out. Usually it's the standard, the longitudinal. Transverse, it's easy to go inside, but difficult to close. Sometimes we do what is called inverted incision, but here we use a standard longitudinal incision. And again, the problem here is the dilatation. When you try to make a pressure over your scope, you loop. So you should know this and try to have a solution for it. Needle in, Dr. Hino. Needle in. And inject. Needle out. So I don't think it to extend the incision, but I think it will dilate the apex and the edges before I try to extend the incision in the mucosa itself. So that's what I try to do now. Just trim the edges so we can try to go inside. Needle in. Now we try to use the power of the water jet and try to adjust our position. Then now we go inside, but we are not so stable. So needle out, inject. So this cut is important to give us some space so we can, enough injection, we don't inject, so we can be stable. Then we have our orientation. Now we did it, we go inside. It didn't usually take all this time, but this case is a little bit challenging, so it takes some time for us to do this. Needle in. Now I landed and I become stable down, then we can demonstrate. Down here is the muscle. You can see the circular muscle is here. We move perpendicular to the circular muscle, especially in this patient because it's a dilated esophagus.
Dr. Madkhour, now you have started to cut the submucosal connective tissue fibers.
Yes.
Yes, that's making for the tunnel.
Yes. What is important in this patient to be sure of the direction because the esophagus is dilated. So we can move to the right. No, it's okay. To the right or the left, and keep moving, not towards the cardia. You know, we move a lot of centimeter to right, to left, not towards the cardia. We are not sure. So it's very important to make sure of our direction. Needed in Dr. Hiwa. If you look here, this is the circular muscle. If we go back, this is our direction always, to be perpendicular to the circular muscle. Yes. So if I move here, I go to the right, here to the left, here to the cardia. So in these patients, especially dilated sigmoid esophagus, it's very important to keep this in mind. Inject. What we are doing now, Dr. Hiwa helped me to do repeated inject. And when we see this nice blue color, so this is the submucosa we can cut, needle out. The length of this needle is around 4 millimeter. I use pre-coag current here. Sometimes I use cutting current, blended current. One tip here, which is important, to have a wide funnel enough. Here, some minor bleeding, so I just coagulate. To have a wide funnel and homogeneous tunnel, I cut from the edge to center like this. And I go to the other side and cut from edge to center. So you usually sure you have a nice funnel. It's okay to have some muscle burn like this. Actually, it's a healthy sign. Again, you can see the landmark. Here is the circular muscle, so here is my direction. I usually control the tip of the spoke. I hold my spoke very close to the patient's mouth, and I use right and left by torque and moving my wrist, if you can see me. So I use my wrist to right and left, so I can control my spoke, and I cut in a fast and organized way. Needed in Dr. Hiwa. Now I go again, I stretch, you know, the mucosa and submucosa like this, and then I inject. Okay, I inject again here. Okay, needle out. And I follow the same rule from the edge to the center, from the edge to the center. This is the school of my mentor, Dr. Lengo. I said Dr. Here, I was talking about him yesterday. So let's see this. So we have one vessel here. We are not sure if we can cut with the knife or not. So what we will do, we will isolate this vessel.
Is it a vessel?
You can see here we isolate the vessel, so we can see how large is it. What do you think, Dr. Hiwa? We can cut with the knife, or we need to aggress?
I think you can cut.
Yes, I agree with you. It's not so big. When it was not isolated, I think all this area is the vessel. But now it's not so big. But when we cut with the knife, we don't move the knife fast. Just let the current cut. So we stay here and do like this. So the current cut, not the knife, so we don't have bleeding. We have another one here. Again, we will isolate the vessel. Actually, we can leave it in place. No, because it's away from our direction. So if we have a vessels, we don't need to cut. We can leave in place. So this lets the healing more fast. And it's good to leave normal vessels in place if we don't need to cut. Needle in. We move down. Again, we inject. I think we're approaching the cardia. Now we are approaching the cardia, so it's become a little bit tight. If I have a wide funnel from the start, as you can see, it's easy to pass the cardia. If I just cut and push, it will be difficult. Inject Dr. Hiwa, because you don't have enough space to manipulate right. Needle out.
Dr. Madkhour, how do you know that you have crossed the gastroesophageal junction?
I just feel I am close, but I am not sure. to make sure, we will show a lot of things here, and we show you our own school, how we be sure of this. Again, here, I don't see blue color, okay? I expect the way is here, but I shouldn't cut without seeing a blue color, so I will ask Dr. Hiwa to inject again. So you may feel, yes, this is a submucosa, but it's better to see the blue color. Please don't press your pedal if you don't see the blue color. Okay? Here is a tricky point, and we can see in those type of patients. Here we cut some muscle, and we have some of them attached to up here. So I will inject up here. Okay, needle out. And I will separate this not to move intramuscular near the cardiac. So sometimes it's a common problem, especially with patients like this. So I don't go down until I solve this problem. Needle in. So when I go down, it's more easy. Now I think you are in the stomach. Inject. I will show you why I think this. So inject here. Okay, needle out. Now you can see it's become wide. Okay, and we will show some anatomical signs, and we will go out to see. But I think we still need to move like 2 or 3 centimeters. Actually, I usually advise to go more in the tunnel, in the stomach. You don't need to cut all the tunnel. You know, I will show you a very nice way how to do this. We have a vessel here, but still I think we can cut with the knife. We use what we say. I let the current cut. You can see now it's become more wide. If I wanted to go right and left, I will. But we will see the oblique muscle and see some other anatomical landmarks. I just extend. You can see how wide it become. Inject here, Dr. Hiwa. Needle out. Again, we dilate here. We have vessel here, so we just isolate the vessel, then decide how to deal with. I think this vessel, you can see it's perforated. It comes down from the muscle, needle in, Dr. Hiwa, to show this. It comes down from the muscle and going up. This is one point. You can see these red dots on the muscle. It's clear here. This is the basidial vessel. So this is a sure sign that we are in the stomach. You can see, or it's not clear?
Clear.
Yes?
Yes. So in this vessel, I have one of 2 options. To go out and I have a grasper, or I can boil with the knife. So I will switch to soft coag. Soft coag, and ask Dr. Hiwa to let the knife out. So soft coag is a weak current. So when I do this, it didn't cut the vessel, but you can see it started to be white. So I will boil the vessel first here, like this. So it's a spurter now. Switch it to spray coag. Spray. And prepare the coag grasper. I believe with spray we can stop this.
So one of the complications of POEM is bleeding.
Yes, actually it's an intra-procedure event. It's stopped now.
Actually part of it.
Yes, it's no problem, but usually injected per here. Usually in third space, you are worried about bleeding and perforation. Okay, but it's usually can control if you know how to do this. Inject per here. So needle out. So we have another vessel here, but also I think we can go with spray coag to cut this vessel. But again, we don't do mechanical so much. I let the knife to cut. Injection. I think we go enough in the gastric side. Needle in. So let's show the coag grasper to show you how to use. We can spray with the knife, but it's not. So we have bleeding here. If I go out, it will increase. You can see. If I go, I do some pressure. So I do this pressure with the cap, like this. I ask Dr. Ismail to switch to soft coag while I'm compressing the vessel with the cap. So I have the grasper out. I go back. I ask Dr. Hiwa to open. He can rotate, but I can do this. I just open. Open. Okay. So close. Close. So now we close. I change the orientation. So the muscle is up and the mucosa is down. So I am not worried about mucosal injury while I'm pressing the coag grasper against the knife, and then it's stop. Okay? So we will ask him to have the coag grasper.
So,
and switch again to spray coil.
Dr. Madkhour, now you are trying to cut the circular muscles at the LES?
No, I will go 1 more centimeter to be sure 100%.
You do not prefer to inject the dye before making the incision 2 centimeters below the GA junction?
No, I show you now. Just inject. I inject here to cut these remnant fibers. Then I go out and I show you why I think I already go more than 2 centimeters in the gastric side. Needle out. Now I start to have like some diaphragmatic movement. So I will ask our anesthesia friend to relax the patient a little bit more. I'm sure she will do to help us. So you can see now we go enough, but I think I should go here for 1 more centimeter. Needle out, Dr. Hero.
When did you stop water irrigation? You decide not to irrigate anymore?
Needle in. Inject.
Okay.
So now I show you the anatomical landmark and why we think we are done with the tunnel. If you go back here, you can see this is oblique muscle. Here, you can see this is oblique muscle.
Yes.
And we can see here, this is a vessel, which is pericardial vessels. And when we go back, this is the tight part, this is the cardia. If we go up and look to the mucosa at the cardia, this is the spindle veins. Then we go out like this to the lumen of the esophagus, and we try to aspirate some water, and then we try to move to the cardia. You can see before we do the myotomy, it becomes lax. This is usually happened with Paul. We didn't do the myotomy yet. But once you go through the cardia, it becomes lax. You can see the difference. And then we go and we suck some air from the stomach of the patient. So our anesthesia friend will be happy. And now I think he starts to be happy we do this. And if we do retroflexion, we may see the blue sign. But actually, this is the least accurate sign because you may have a transmitted fluid after you inject. So I think we go to here. And now I will show you when we're doing the myotomy, the most sure sign. To be sure, we already go beyond the gastric side for 2 or 3 centimeters, and we are doing it in sufficient way. Again, we do suction. You can see how dilated the esophagus here. You can see it's like stomach. You can see this view. That's why we have some challenges to go inside. And again here, it will be always challenging, but again, we will try to save the same model we use, do some pressure, and go reverse it, then adjust ourselves like this. So we start the myotomy like 1 centimeter below the incision, and we do selective myotomy followed by full thickness myotomy, and we can do full thickness myotomy from the start. It's not an issue. Before they think that will increase their flux, but it's not related. Now we will ask Dr. Hiwa to have the needle out. And first cut here, we do little bit superficial, so we can see the plan, our plan. It's a thick muscle, so this cut didn't totally cut the circular muscle. So we repeat again, and go back, needle in, Dr. Hiwa. So we can see the plan here. You can see, here is the longitudinal muscle, here up is the remnant of circular muscle, needle out. So we will follow this plan. We take this circular muscle and move up and start to cut toward the center. Now it's clear, you can see this. I wanted some photos, okay. Dr. Hiwa asked me to take 100, so I take 1 now, and we have 99 to take. Okay.
Thank you so much.
So again, we follow this plan. Actually, we just try to demonstrate this, but in real practice, we can do full thickness from the start, and we don't spend a lot of time to have this plan. So if we have some bleeding from the edge, we coagulate. So we have some, no, it's okay. We just will spray this.
دكتور أراز أجا برسيار هي بومان بنيرن.
I told them if there is any question, I can transfer the question to them. Yeah. Sorry, Ustad. No, that was before the procedure. There were islands of hemorrhagic mucosa. Sorry?
Yeah, in the stomach you mean?
I don't know. This is not my case, and I have not done the endoscopy for him, sir. We can ask...
to do the procedure with H. pylori positive?
Yeah. دكتور مدخور. أستاذنا الكبير دكتور مكي يسأل before the procedure there were hemorrhagic islands of the mucosa of the stomach. Is it safe to do the procedure near to the cardia?
Yes. No, usually those patients have this type of gastritis, and once it's not malignant, it's the only issue to have a malignant lesion. Even if we have ulcer, gastric ulcer, no problem. But it shouldn't be in the esophagus. Now we will start the full thickness myotomy. We have some minor bleeding here. We will spray and we will go for the full thickness myotomy here. Here you can see this is the adventitia, and we follow this plan. We try to use coagulation in the beginning, then we use to endocut, and this is the plan for full thickness myotomy. Now we moving before the cardia by 3 centimeters. We go for full thickness myotomy. You can see it's clear here. Again, we follow same plan. We use coagulation first, then we use cut, and let the knife do it herself. I just give a little bit pressure and go up and cut. And again, we are moving to the gastric side and cut. Again.
Dr. Madkhour, just for joke, you have created a new esophagus. Why you will not close the oldest one and to use the newest one?
Needle in. I don't get the questions.
He said you created new esophagus.
Yes.
New one.
Okay. Yeah. Okay. So this is, you can see this is paraesophageal vessels. We didn't need to cut this. Okay, and then we continue here. Again, we cut needle out.
So you always cut the muscle from the incision through all the way?
Yes, needle in. But I wanted to cut 1 more centimeter down, and I show you why. Inject the here. And this is very important. Our aim of doing boil, not to create a tunnel, inject, needle out, not to create a tunnel. Our aim to do a sufficient myotomy. So if we are not sure, we should continue. Why I'm not sure here? Because I didn't see the peritoneal fat very well. So although before I go for myotomy, I think it was enough. I'm not sure now, so I inject above the edge, needle in, and I will tunnel for 1 more centimeter, and I do a myotomy again. This is important. Needle out. And I believe this is the most sure sign. We go enough in our tunnel to see the peritoneal fat. I can see peritoneal fat in esophagus. So that's why I decide to go for 1 more centimeter here and then to do myotomy here again, extend the myotomy.
What will happen if you will extend more than 1 cm in the stomach?
We go from the stomach in 2 centimeters below the cardia. If I go more, I increase the incidence of reflux. If I do less, I have insufficient response and the incidence of recurrence. So it's important to do it in the right way. You can tunnel more than 1 centimeter, take the needle in. Let me show you this now. You can see now, this is a peritoneal fat. It's clear here. This is peritoneal fat. So we are sure 100%. Okay. So we have to go this 1 centimeter or 2 to make sure. So this is peritoneal fat. And we go and aspirate to see. So this is the most sure sign. We go enough. But you couldn't know this until you do the myotomy. You can see this is a crossing vessel here in the base. But I think we will coagulate, not to have a delayed bleeding. Now we go enough. This is gastric side. This is peritoneal fat. And it's like an opening here. It's different from here. If you look here, you can see some structure in the back, but down here, it's peritoneum. So I will ask Dr. Hiwa to the grasper to coagulate this vessel. Why I will coagulate this? Because it has some oozing. If it didn't have this oozing, I will do nothing. But with this oozing, I will try to coagulate not to have a delayed intra-tunnel bleeding. We can do culture.
Is late hemorrhage one of the complications late after surgery?
Yeah, it's very rare. It's very rare, but I don't have any case of delayed bleeding, because actually sometimes when it's minor, it will collapse inside the tunnel, open, and it's already in a closed space, but we should do this prophylactic coagulation. Close. After we hold a soft coag, open, close. Again, we don't coagulate all vessels in the base, but this because it oozes. But here, we should coagulate. Open. Dr. Amr just tell me, take care of these. No, open. Not to take me closer. Open. Yes, now close. Open. Close. Now I think we're done. What do you think, Dr. Hiwa? We need to do any more coagulation?
I think amazing work.
Perfect. So we've done. This is the selective bar, and we go out. We check the mucosa again to make sure we don't have a mucosal injury after the myotomy. You can see the cardia is widely open, baby. And again, we do some suction from the abdomen. And I will ask Dr. Amr to help us to do puncture, and it's nice to show this. So this may happen in like more than 25% to 30% of patients. Why this happen? Because I was showing you now the peritoneal fat. So we have some CO2 escape to the peritoneum. This is normal. So we will puncture, then it will be released. Then the patient didn't have abdominal pain after the procedure.
How you feel the G junction?
Yes, it's now very relaxed. You can see here. And now we will go for the closure. Here it may be a little bit challenging because we expect the mucosa is thick. It's not easy to suck, but we will try our best again. Any questions?
What will happen to this tunnel in the following 10 to 14 days when you close the incision?
Yes, actually, some studies, some Chinese do some studies, they usually go on second day and fourth day and sixth day to see what is happening. Nothing is happening. Very few clips may fall down in the first few days, but actually in 48 hours, this tunnel collapse. So sometimes we have some patients who develop thromboembolic event, a patient who has pulmonary embolism in day 2. So we give him anticoagulation. We are not worried. Actually, this tunnel totally will collapse.
Okay, have you met a case of previous surgical Heller myotomy?
Yes, I did.
Okay. Have you met a case to do another poem for a failed previous one?
Yes. Actually, I did like more than 40 cases who do previous Heller myotomy, and I have 3 cases who do 2 Heller myotomy. So he did one, maybe 25 years open, then he do another one, then we do both. It will be more technically challenging, but still you can do. But it will depend also on the size of the esophagus. Sometimes the size of the esophagus is hugely dilated. So even if you let the way going well, the patient symptom will not improve very well, but we do also before we advise the patient to do esophagectomy.
So if the procedure was anteriorly approached, you will go posteriorly in the newest one?
Yes. Usually surgical, we will tell. Usually surgical is anterior, and we can do anterior or posterior. Just like this. And sometimes we do even after bone. If you have previous bone, we can do rebone. Open. And the guideline, let it open for those who do bone, but close. I want, first clip is very important and the most important clip. And we have the problem which we have during entry.
posterior
that
wall.
we are looping. It's not horizontal. So I think to close the same way I do in the incision. And I will need the help of Professor Hewa to help me to have a good position of the clips so we can do this. Actually, what I am doing is not the standard. What I do in this case, because of this difficulty, let's rotate this. Yes, this file open. I will close as if it is anterior.
So, Ustad Madkhour, the longitudinal incisions easier to be clipped than sutured.
No. Open. Suture is very difficult in esophagus, actually, and we don't have overstitch here or even in Egypt, and it's not wise to use. It's very expensive. Clipping always usually do the work.
Don't practice it in Egypt.
Just a second. Open here. Close slowly. Close. Yeah, fine. So I think it's fine, but I will add one before, then I continue. But this left the two edges closed, so I will try to do one down, then I continue up. Usually the first one I shouldn't do one before, but again we are here in a very special situation. You can see the cavity. We are moving in, so we couldn't go down to get the pressure to the clips. And we are looping when we're doing this, so we use this modified technique. Open. Yes. Just close. No. Close. Open.
Open or fire?
Close. Yes, fire. Okay, now we are satisfied by the back, and we continue here in the front, and we do some reinforcement for this clip. I think the other clips will be more easy. Usually we spend enough time to add the first clip in the right way. It will make the whole procedure easy for closure. Actually, this is an easy step, rotate Dr. O, but very crucial step, because if we didn't close in the right way, we will have a leak, we will have a mediastinitis. Open. So we should spend the time to make sure we do this easy step in the right way. It's easy but dangerous.
How long it takes time this incision to heal?
Close. Yes.
Fire.
Actually, after 2 days, it's totally collapsed. And these clips fall down after 2 months. Sometimes we do follow up for some patient. After 6 months, we found some clips, but this is not traditional. You can see now it's more easy. Now they are straight, so we can have only one here, maybe two, but now it's more easy. If we didn't do this in the right way, we will not see this view.
Does the patient feel anything after the surgery, of the procedure?
Again, please, I'm sorry.
This clips on the whole procedure. After a while, when the patient will wake up, is there any special feeling for the patient? Dysphagia, pain, chest pain?
Both, yes. We may have some chest pain because we have a lot of electrosurgical current. Here was close to the mediastinum. Open, close. Open, and to do some pressure. Open. So usually we use non-steroidal for this pain because it has anti-inflammatory effect. Close. So it's more effective than any painkiller. So it's more effective than any painkiller. I think now it's fine, and we should check the right and the left. We will check. Dr. Amra advised me to check the apex. We check the right and the left and the apex. I think it's fine, but we check the other side again. I think it's fine. Here, it's the rules. Yes. You think it's fine, Dr. Hewa?
Yes, but
last
picture.
I think it's fine. Okay.
You on 92 picture.
92, so we can take the rest of the 100 here.
Ustaz Madkhour, is there any risk of the nerve injury during the myotomy on the cardioesophageal junction?
Anything may happen, but if you do in the right way, you will not. We didn't have any thoracic organ injury in all our series, but some reported cases in the literature. Some do injury for the diaphragm, they think it's muscle, then they do cut the diaphragm. Some do cut the pericardium, one reported case, because he think it's a muscle. So it's a demanding procedure. It has some skills, but also knowledge. You should be oriented with the anatomy, oriented what is here.
Really,
what
this
may
is
be here.
considerably significant, especially if the patient had history of the hilar myotomy before, maybe nerve injury on the anterior again.
Yes, actually, when we operate a patient for previous hilar myotomy, we have more problem in the cardia because of the red. So sometimes we have mucosa is turned around, sometimes we have a mucosal injury, and we try to keep the red. So we do the poem and he get benefit of the old red.
Do you need?
And after hilar myotomy, we do usually posterior.
Yes, you can see now. You can see this. Now this is the cardia.
The testing.
Yes, you remember in the
Test,
beginning when we need to push water and the push to go this. Now this is the cardia, and we aspirate the rest of the air from the abdomen. Dr. Amri Foodi do puncture for the patient. Everything is okay. So when we do it, we look here in the anesthesia on the peak pressure, because if we have air escape to the lung, if we have pneumothorax, it may happen. Everything may happen. You shouldn't be worried, but you should know it may happen and how to manage and how to avoid. So we usually keep eye on the peak pressure, keep eye on the CO2 level, make sure our CO2 level is not so high, peak pressure is fine. So we usually talk together. You can see here the mucosa.
No any injury.
Yes, no injury, but it's very sick and indemitous because it's a neglected sigmoid achalasia. And now we're done with the procedure. We should do nice suction here, so we can help our friend from anesthesia while he removes the tube. So we do this.
Do you need antibiotic pre or post?
Guidelines say you don't need, but we give antibiotics post-spoil. We give for 5 days.
Ustaz Mazkoor.
When he's in the hospital, then he go out.
Ustaz Mazkoor.
Something like this.
Is there necessary to routinely do a chest X-ray to exclude pneumothorax?
Dr. Aras, we usually admit our patient for 24 hours.
Yes.
Our policy. Otherwise, there are some centers, I think, they discharging the patient even after few hours. What do you think?
Yes, actually we do the same. We admit for 24 hours if it's straightforward like this. But if we have a patient with significant bleed, or we have a mucosal injury, if we have a pneumothorax, we manage, but we keep for like 2 days, not 1 day. And there was an interesting paper published in GIE in some centers in the state, and they discuss same day discharge for this patient. But they do in the early morning, and they discharge at the end of the day, like 6 or 7 p.m. But actually, we should know the condition of our countries. There in the state, if the patient have any mild symptoms, he will call the resident and he came back. But here, the patient may have some pain, some tachycardia. He say, I will be fine, and it be serious.
Yes.
So I prefer to keep under our eye for 1 day at least.
Dr. Mazkoor.
Dr. mentioned, we usually do under GA with intubation. This procedure should not be done without GA.
It's mandatory. It's not optional. We have something is not optional. It's not optional not to use CO2. If we don't use CO2, we are killing the patient. Okay, and it must be done under general anesthesia. We should follow the peak pressure, follow the CO2. We may have some pneumothorax. We may have all these complications.
With wonderful team of anesthesia.
It's one team. Without the wonderful team, he will not be relaxed. I have the mucosa near me. We couldn't finish. Also, by the guidelines, Japanese guidelines, recommend to do this in a center who have a CT scan, in a tertiary center.
Cardiothoracic surgeon.
So I have one friend in UK. He do ESD very well, and he didn't do BOM. I asked him why you didn't do BOM. He said my hospital didn't have a cardiothoracic surgeon, so he didn't have the license to do BOM.
We have a very wonderful team, Dr. Kalender and other surgeons. He's supporting us. So
that is the success.
We have a very strong backup for surgery, so we don't afraid from. What about feeding, sir? When we feed our patient?
Yes, actually, after 1 day, we give clear fluids. If he fine, he go home. and he started normal feeding after 2 weeks. We go gradually, clear fluids, then thick fluid, then soft diet, then more thick diet, then he started to eat normally within 2 weeks.
Antibiotic, which antibiotic you prefer given to patient?
We give first generation cephalosporin during his hospital stay, and then we go out on quinolones or any oral antibiotics.
Do they have any question, Dr. Aras?
Dr. Ustad Makki has a question.
Dr.
Yes,
Madkour, I think you an abnormal stomach. How often do you see abnormal stomach in achalasia, number one? If that was H. pylori positive, what's the risk post-op? And you know H. pylori can cause autoimmunity related to achalasia, and the H. pylori can cause cancer of the stomach and lymphoma. How confident are we just ignoring the redness in the stomach? Please, can you comment?
Yes, you are totally right. Before we do this, we do examination, full examination. Actually, I didn't do this because I trust Dr. Liwa. He do this patient, I think, 2 weeks before.
Yes.
And he do full examination, and he found the full with food, so, and some fungal infection and some ulcer. So he added in prolonged fasting and he gave medication. But you are totally right, and I agree with you 100%. But I just depend on my friend. He do this before.
Yes.
Dr.
We
Hawa,
check for
Dr. Hawa, you do the endoscopy. That was red stomach.
Yes, we did. Yes.
So this is pylori.
The stomach
Yes.
was inflamed, sir, and there was some gastric erosion, as you see on first endoscopy in the morning. There is some inflammation in the stomach, but Helicobacter pylori status was negative, sir. This patient prolonged history of dysphagia more than 7 years, I think. He's a friend of mine since childhood. Didn't tell me this have problem. So during endoscopy was a lot of food in the esophagus. We cleaned the esophagus, and there was some fungal infection. He's receiving PPI for high dose PPI for the last 2 weeks, and antifungal infection fluconazole also for 3 weeks. That is why today the mucosa was the integrity was very good. No any esophageal ulceration.
Again, a nice step you did, and we do, and for Amr and our team to give this antifungal. So usually we do for long-standing achalasia, even like 4 days before the procedures, even if you didn't have a definite fungal infection. And it makes the mucosa more healthy and more easy to deal with.
Our worry after POEM is the reflux one, and we know that we have 2 types of reflux, high acid and low acid reflux. High acid because of GERD, and the low reflux because of the stasis. And I think this is a good message for all of us to make good, treat the stomach first and check how much reflux, because our worry in the future is this. We are not doing now anti-reflux surgery, only POEMs, huh? And this patient risk of reflux is 30%, yes? Thank you very much.
So this is maybe because the procedure is new in some of our Arab countries, we discuss a lot. But all over the world, actually, it's totally established. We have an incidence of asymptomatic reflux, like 40%. 40% may have erosive esophagitis, 20% have symptoms. In general population, the patient who has reflux around 14 to 16. So it's an issue, yes, it's an issue, but it's not a major issue. These all are all the publications. There is a lot of new data that the reflux much more lower than this. But until we publish our cohort, we will talk about 20% symptomatic reflux. Maybe after we are sure the patient is totally free from the main complaint, which is the dysphagia, and we don't have recurrence, we try to do anti-reflux procedures, surgical or endoscopic. A lot of anti-reflux endoscopic procedure can be done for the patient, but I don't recommend to do this so early, not to do this now in the same session. Actually, some doing this, and you can find a lot of publication on sensation POEM and TIF, and POEM and POEM F. Okay, again, we agree we have an incidence of reflux, not so much, maybe very close to the prevalence of reflux in normal population. And when we have this problem, we can think about anti-reflux procedure. Finally, 100% of those patients response on BBI. So all patients who have reflux, 100% response on BBI, but the patient should be consented for this. When you do him the procedure, you tell him 20%, you may have reflux, need treatment. Okay, you do. If he refuse, okay, it's his right. You should, you
we explain. I always, this patient, I explain for him that We may do balloon dilatation, but you need repeated session. You can do laparoscopic hilar myotomy by expert GI surgeon.
Yes.
You can do POEM procedure, which we do.
And actually, all over the world, POEM is the standard of care now for dealing with achalasia.
Let me receive some questions from the audience, please.
Dr. Alasgan, if you have question rapidly, because another room ready, we want to start.
We will receive only 2 questions.
Yes,
First,
please.
Doctor.
Thank you for nice demonstration, and proud of you, Dr. Hiwa. A question for Ustaz Madkhour regarding technical, any different regarding difficulty to start myotomy from below or above, according to your experience. Thank you.
Actually, on standard we do like this from above to below. Here in this patient, if you notice in the beginning of some cuts, we have some problem in looping in the esophagus. Short answer. Some few doctors do incision from down to up. Dr. Amrita, my friend, she doing this. I do this only if I have a very tight cardia and a very close mucosa near the cardia. I cut the cardia first and go down, then I go from up to down.
Rescue
procedure, yes, but not the standard.
Yes. Another question, a final question, Dr. Aras?
Yes. Any question? No more question. Well done, thank you.
Dr. Aras,
thank you. Yeah.
Please,
Yes.
I have one
Yes.
question.
Yes.
Thank you for your this good job. I am Dr. Diler Omar from Kirkuk, Dr. Hiwa. My question is, what are the superiority or the advantage of this procedure over the surgical classical inhaler myotomy?
Actually, both are myotomy. Both are myotomy. So if you do both in the right way, they will have the same results. Okay. We found a lot of insufficient surgical myotomy, but the problem not in the procedure, the problem in the operator. But if experienced endoscopist and experienced surgeon do in the same way, both are surgery, are myotomy. Surgery may have a benefit of reflux, which we discussed in. Here we have a benefit of tailored myotomy. What I mean by tailored myotomy? We cut what we want. If we want to cut 25 centimeters, we can cut. If we want to cut short, we can cut. So this is the tailored myotomy. Procedure time is very low. Sometimes this is a complex case. Sometimes we do this in less than 30 minutes. So procedure time is lower, hospital stay is lower, recovery is faster, and this is minimally invasive. Usually we try, if we couldn't use staples, it's better.
We will shift to Dr. Sivan now. She will present the second case, and Dr. Ustad Hussein Okasha, he will start the procedure in the second room with Ustad Dr. Taha Karbuli. Please join us in the second room.
Thank you.
Thank you.
Yes, Dr. Sivan, start. We cannot hear you.
With history of recurrent pancreatitis, she's diabetic on oral hypoglycemic agents. She has HbA1c of 8.4% and a lipase of 4.4 during the attacks. Now she has 2 previous history of ERCPs, last one done 6 months ago, showing irregular main pancreatic duct and multiple pancreatic duct stone for which extraction done and pancreatic duct stent deployed. Her most recent ultrasound shows multiple variable size stones. The largest one is about 26 millimeter and 17 millimeter multiloculated sac collection (resolving pseudocyst.
Thank you, Dr. Sivan. By the way, there is coffee break till 12. If anyone wants to his mind, he can take it. Okay. So
أعتقد ده يحكي أوكي بس عندها
Hepatitis is multiple, so we do MRCP, CT, and US to detect a cause of recurrent acute pancreatitis. The commonest is small focal lesions, small cystic lesions like interductal papillary neoplasm, cystic pancreatic neoplasm, small solid lesions, CBD stones, pancreatic duct stones, autoimmune pancreatitis. So there are many cases, many causes which can produce recurrent acute pancreatitis. Here, this patient has frank history of pancreatic duct stones with previous attempts of removal of the stones and insertion of pancreatic stents. As we see in the endoscopic picture, there is a pancreatic stent. So we are now exactly at the papilla. Now we will start the examination. I'd like to start the examination from the duodenum, from mid-second part of the duodenum. And here we go to the, now we will suck all the air, as this is a papilla with a pancreatic stent. So I will suck all the air and start to induce anti-clockwise. This is the pointer, so this is the papillary region. And here, this is the papillary region and starting of the pancreatic duct. Here, after insertion of a stent and after pancreatic sphincterotomy,
just to make sure that they have sound. Dr. Aras?
Yes.
Yes,
yes, the sound is very clear, with the field is clear.
If there is any interruption, please inform us.
No, both voice and picture are okay.
Thank you.
Okay, so we are now in the mid-second part of the duodenum at the site of the plastic stent inserted in the pancreatic duct, and here this is the papilla. And we notice here there is an echogenic structure. As I told you, when you insert a plastic stent, whether inside the pancreatic duct or the common bile duct, there will be air after pancreatic sphincterotomy. So you have three structures which are echogenic. Echogenic means whitish. Echogenic means whitish. The stent is echogenic. The stone is echogenic. And the air is echogenic. So after pancreatic sphincterotomy, you have stent, echogenic air entered from the second part of the duodenum, and the stone is echogenic. It is a crescentic form, crescentic echogenic structure. So it is somewhat difficult to differentiate between these three structures because the three structures are whitish. But there are some features which can differentiate between them. The stone is crescentic, hilal, crescentic, with definite posterior shadow behind, with black shadow behind the stent. This is characteristic of a stone. Behind the stone, yes. So if I find this structure, whitish structure, it may be a stent, part of the stent, it may be a stone, or it may be an air. But as you see, it is crescentic and definite posterior shadow behind. You see this line, we will see more clear. First to start, we will measure this echogenic structure. It is about 7 millimeters. As you see here, this is the stent, like the sign of equal, two lines beside each other. So this is the plastic stent, wall of the stent, and other wall of the stent, I will magnify. This is wall of the stent, other wall of the stent, and this black line is the lumen. So this is the plastic stent.
Tram line.
Yes, equal?
Tram line.
Tram line, yes. Okay, so to me it is definite the stent. It is not a stone or air because they have the sign or equal or tram lines and the lumen in between. And this is the papilla. But here I am sure by about 90 to 95% that it is a stone. Air producing what is called the comet tail appearance. Comet tail is a whitish luminescent line like the star in the sky. When it descends suddenly, a white line, very nice, seen in the dark nights. So it is called comet tail. Comet means star or muzannab. Tail is the tail. So it is a tail of the shahab al-saqit. Tamam? I see that it is a stone, and here this is the stent. We will continue examination. Yes, there are multiple stones. You see? There are multiple stones in the pancreatic duct. I will go out here.
Dr. Hussein, I am asking why we are on need of EUS for this patient.
EUS?
What for? I think they mentioned it is by the MRCB, there is a stent and there is stones. Is there anything extra we are on need for by EUS?
No. It's a very good question. What is the indication of endoscopic ultrasound here? First, to confirm the findings of MRCP. Number two is to give more details about the status of the pancreas, the number of stones, and the size of the stones, because it differs much in the management later on. There are many lines of management in this case. First line is ERCP and extraction of a stone, and it was done before, and no convenient results because there are many stones. This is the first line. The second line is extracorporeal shockwave lithotripsy, and it is not available in my country, and I think it is not available here. It is available for renal stones. The third one is spyglass through the pancreatic duct and hydraulic lithotripsy, electrohydraulic lithotripsy. The fourth one is surgery. So we should have a very accurate topography of the number of the stones and the site of the stones, because it will differ in the line of management, and if surgical, it will differ among many types of surgery for pancreatic duct stones. Here I can see a row of stones, very large number of stones, 1, 2, 3, 4, 5, 6, 7, large number of stones. So let us discuss the management of this case after finishing. I'll finish rapidly. Here the pancreas has a very heterogeneous structure. This is the head of the pancreas, very heterogeneous structure, and this is the wall of the duodenum. There is edema and inflammation of the wall of the duodenum. The thickness of the duodenum wall is about 13 millimeter. Usually it is less than 4 millimeter. So it has a full-blown picture of pancreatitis. So heterogeneous pancreas, lobulated, exaggerated lobular pattern, a large number of stones, at least here 10 stones in the pancreatic duct. And this is the head of the pancreas. We can find a cystic lesion, it may be IPMN or something like that, but it is not appearing in the first examination. So if you find a collection, then it will be post-pancreatic. And here we can see there is post-pancreatic collection. Yes, here there is a collection, here. It is a pocket of echogenic fluid around the pancreas. This is, yes, and this is a collection. This moving fluid is inside a collection. Here, this is the liver. I am now maximum anti-clockwise. Okay, so there is a large number of pancreatic duct stones here, markedly heterogeneous pancreas, and here it is a pocket of collection. So these patients has acute on top of chronic calcular cholecystitis. This is an acute pancreatitis because there are collections and the pancreas is markedly enlarged and heterogeneous. But the presence of pancreatic duct stone, this means that it's a chronic pancreatitis. The only sign which differentiates acute from chronic is the stones and pancreatic calcifications. Both acute and the chronic pancreatitis can produce heterogeneous pancreas, can produce enlarged pancreas, can produce honeycombing. But stones or pancreatic calcifications, this is characteristic of chronic pancreatitis. So this is a major, according to Rosemont classification. There is Rosemont classification, the most famous classification for chronic pancreatitis. There are 2 major A, 1 major B, and multiple minor. 2 major A is pancreatic duct stones, pancreatic parenchymal calcification. These two measure A. One measure is honeycombing, gathering of the nodular pattern of the pancreas in small groups, like honeycombing, and multiple minor criteria. So according to Rosemont classification, this is definitely a chronic pancreatitis. But the presence of collection, this means that these patients really has acute on top of chronic calcular pancreatitis. Now I will, this is a collection here and the heterogeneous picture says. Now I will examine, here you see this is the...
In such cases, do we need to rule out malignancy or autoimmune pancreatitis, or you are enough with this?
I am enough. Why? Because malignancy cannot produce this picture. For a stone to be formed, it takes many years, and the malignancy will not stand for many years. But there is an important fact that 10% of patients with chronic pancreatitis will turn malignant within 10 years. 10% within 10 years. So one of the benefits of imaging, whether CT, MRI, or EUS, is to exclude malignancy. But here in this case, it is very difficult or even impossible to diagnose malignancy in that heterogeneous pancreas. There are many heterogeneous areas. So the rule all over the world that if you want to detect malignancy in a background of pancreatitis, you should do the endoscopic ultrasonography at least 4 to 6 weeks after the end of the acute pancreatitis attack. You can do it in the chronic phase, but not in acute phase, because in acute phase, the pancreas is heterogeneous with multiple inflammatory and necrotic area. So here it is impossible to say that there is a malignant lesion. But I didn't think so that it is a malignant one, because there are many stones taking a very long time, so the malignancy will not stay for that long time. But you are right, 10% of patients with chronic pancreatitis will develop malignancy within 10 years. Autoimmune pancreatitis, this picture is totally against autoimmune pancreatitis. Autoimmune pancreatitis is not famous for pancreatic duct stones, and it's not famous for pancreatic collections, because it is a subacute or chronic pancreatitis. There are type 1 and the type 2. Type 1 is a chronic pancreatitis or subacute. Type 2 may be subacute, but is not famous for this aggressive acute form with collections and heterogeneous pancreas. So I am against autoimmune pancreatitis and against malignancy. Here I will examine the pancreas from the fundus of the stomach, 2 to 3 centimeters below the cardia. My landmark here is the aorta. This is the abdominal aorta. Yes, the upper part of the abdominal aorta. Yes, and here this is the body of the pancreas, because these are the splenic veins, splenic artery and splenic vein. Here at that level, this is the pancreatic body. Okay, I will go clockwise to go to the pancreatic body and the tail. I will enlarge the field. This is the pancreatic body. This is the aorta. This is the celiac axis, giving the splenic artery and splenic vein. Now clockwise. Yes, here this is the spleen, and here this is the kidney. And we notice here there is a dilated structure here. I think this is the splenic vessel. So we should go Douglas. No, yes, this is the splenic vessels. Okay. This is the splenic vessels. And this is the left kidney. Okay, then we are in the pancreatic tail. We will go to the body. And here we notice that there is a wide structure and not taking color flow signal. Not taking color flow signal. So this is the dilated pancreatic duct. Classic, it is significantly dilated. And the stent is not seen here because it is a short stent.
The stem not functioning.
What?
The stem not functioning.
Not functioning and not visualized here, because this is the region of the tail and body. And the stent is very short. Usually pancreatic stent is 5 centimeters.
Could be this explain that she got another attack of acute pain and vomiting for the last 4 weeks, non-function obstructive pancreatic stent?
Maybe, but even if the stent is functioning, these patients will suffer much because she has a large number of stones. This large number of stones will induce acute pancreatitis even with the presence of stent, because it is not one stone or 2 stones you are bypassing it by the pancreatic stent, but you have a row of stones, more than 30 or 40 stones filling the pancreatic body and shaping the pancreatic bed. So you should manage.
What do you recommend?
I will tell you my recommendations just 2 minutes after finishing the examination. This here, the pancreatic duct. I will keep the color flow Doppler. Anti-clockwise. Yes, this is the pancreatic duct, and here a large number of stones, horrible stones. This is the pancreatic duct, and here we can notice that there is here a large stone, and you see here beautifully the posterior shadowing behind the stone. So someone may tell me that it is air. There is pancreatic sphincterotomy and there is air inside the pancreatic duct. Someone may call it is a stent. No, it is a crescentic shape with definite posterior shadowing. So it is definitely a pancreatic duct stone, and it is large stone. Stone is about, and very, very important to measure the largest stone because it will affect management later on. This is about 13 millimeter. A very large stone in the pancreatic duct. Yes, here. It is a row of stones, and the pancreas is heterogeneous. So, coming to the question of Dr. Hiwa, what is the management? I think extraction by ERCP is useless. Will not manage. Shockwave lithotripsy is not available. A spyglass or cholangioscope may work, but I think this is a large number of stones. To do hydraulic or laser lithotripsy for this large number of stones, you will stay for 6 hours, for 6 sessions. So it is very, very tedious maneuver. The large number of usually surgery, if more than 5 stones and the largest one more than 10 millimeter, then I should go for surgery. And here surgery is 2 types of surgery, pancreatectomy or post-op maneuver. Pancreatectomy here is a very hazardous operation because you should remove the whole pancreas. It is a very, very, very aggressive maneuver. But I think here post-op maneuver, post-op means pancreatico-jejunostomy, to open this wide pancreatic duct on the jejunum, and then during the operation, the surgeon milking or moving the stones in the pancreatic duct to extrude them from the pancreatico-jejunostomy anastomosis. Anastomosis between the dilated pancreatic duct. Surgeon loves this operation because the pancreatic duct is dilated, so you can make the anastomosis very easily, milking the stones, getting it out to the jejunum, and then you leave a very big anastomosis between both, so it is very nice for drainage. A very interesting case, and I am ready for any debates.
Before knowing the surgeon opinion, what about ISWAL for this patient? ISWAL.
Extracorporeal. I mentioned it. I just mentioned it.
Yes.
Extracorporeal shockwave lithotripsy.
For this patient,
it is not available in my country.
It
is available only for ureteric stones.
Yes.
But if you have it, I think it will not management in this situation because you have 30 stones. You will do shockwave lithotripsy for 30 stones. It will be how many stones? 60 or 90 stones.
The problem of this patient, she always refuses surgery. We sent her 3 times for surgery. She refused surgery.
But if you tell her that the surgery is not aggressive, the surgery has very, very minimal complications, choose for her the post-op maneuver, not the aggressive pancreatectomy. If the stones are limited to the pancreatic duct in the head region, you can do Whittle. If it is limited, stones are limited to the body or tail, you can do distal pancreatectomy. If the stones are present throughout the pancreatic duct, you should do total pancreatectomy. No, we don't need that at all. We don't need just pancreatico-jejunostomy. And here it will be rather easy because the pancreatic duct is dilated. Yes. When the pancreatic duct is dilated, the surgeon finds enough space to do the anastomosis easily, and during the operation, milking of the stones to extrude it out, and the large opening will allow for an instantaneous drainage of any pancreas, so no stones will form later on.
Ustaz Hussein, is there any stone in the head?
Yes, the head is full of stones.
Why not the drainage procedure and resection? For example, Frey procedure. You not remove the pancreas.
Dr. Umar, you are, Dr. Umar, he's with us now. I think he's one of the moderator in the session. You are an expert pancreatobiliary and GI surgeon. Which surgery you prefer for this patient, Dr. Umar?
The distal pancreatectomy, the total pancreatectomy is destructive, really. But
yes.
We can choose the drainage and resection procedure, Frey procedure. Both the pancreatico-jejunostomy and inoculation of the head with a retrieval of the stones. It is better than the total pancreatectomy or pancreatico-jejunostomy, for example, pesto, because the stone is remain in the head if you do the pesto. The pain will
Yes, Dr. Taha, you want...
Dr. Omar, let me tell you something. I noticed many patients underwent surgery, this is what you mentioned, but after a few years they will go to recurrent pain. Although I agree with you totally, total pancreatectomy to end with the brittle diabetes. But yes. Another problem, apart from recurrence of pain, how we can exclude occurrence of the pancreatic cancer on top of this heterogeneous mass at the head? And this is another question to Professor Hussein. By EUS, what are the modalities available? If somebody asks me, this is heterogeneous mass, how you are going to use elastography, solar view, to target certain area, to take biopsy, to make sure this is because, you know, in heterogeneous mass, it's difficult to differentiate mass from pancreatic cancer. And pancreatic cancer itself is a risk factor for pancreatic, chronic pancreatitis. Risk factor
10% in 10 years.
I agree with you. Total pancreatectomy is very
aggressive. I don't recommend it.
But on the long run, Dr. Umar, from your experience, you notice how many patients they come with recurrent pain after doing this surgical procedure for the patient?
Of course, some of them will recur with this pain.
We might resort later after this surgery.
CPN of the patient.
Yes.
What do you think about
CPN or
CP block, celiac plexus block after surgery if the patient got pain? Is it useful?
It is a temporary. Of course, it will be useful, but it is not. It's not treating. It's not treating the original disease.
How do you think?
I mean, after surgery, if the pain recur, we can use. We can do EUS guided celiac plexus block.
Yes, of course. You mean celiac plexus block, not neurolysis.
Yes, block.
Yes. But if pain recurs after surgery, we should search for why the pain recur. We should do investigations because the stone may recur. And you should treat the stone because this is a chronic disease. And celiac plexus block stays, the effect of pain relief is about 1 month. So it is impossible or non-logic to do celiac plexus block monthly for a patient for 20 years or 10 or 20 years. So if pain recurs, you should search why the pain recurred. If the stone recurred, you should manage the stones. And celiac plexus block, okay, you may do it, but for temporary palliation. But the original cause should be treated, which are the stones in these patients. This is not a malignant patient and short life expectancy. So you can do neurolysis or block. The patient will live for 10 or 20 years. So here block and lysis is not the issue. The issue is why the pain is there. Surgery, very nice. It will relieve the pain. If the pain recurs, then the stones recur, and we can do something. If it is 1 or 2, then we can do, for example, spyglass electrohydrolysis. Yes.
Yes.
question for you, please.
May I have a comment, please? Thanks
Yes,
for nice demonstration and very good discussion. Just regarding this case and approach to treatment, I was for a period of about 1 month in AIG, which is a good and advanced center for pancreatobiliary intervention. On daily basis, they had up to 10 or 15 cases just like this case, chronic calcific pancreatitis with multiple different size pancreatic duct stone. And daily they were doing ESWL, shockwave lithotripsy. They were putting a stent just after the lithotripsy, and they repeat ERCP after 3 months, and they were removing the stones without sending for surgery, which may need total pancreatectomy with a lot of complication. So if patient wants non-surgical procedure, we can refer to centers with availability of such procedures.
Yes, yes, I am with you. Very nice. It is one of the treatment options, but it is not present in my country, in Egypt, and I wonder if it is present here.
No, of course not.
But it is very nice. But if you, in this case particularly, when the stones becomes more in number and more and larger in size, the shockwave, the failure of shockwave lithotripsy becomes higher. Shockwave lithotripsy is very nice, and when I was training US in Germany in 1997, they are extensively using shockwave lithotripsy, but not for that large number of stones. It is at least 30 stones, and the largest one is 13 millimeter. So you can try it. You can try it, shockwave lithotripsy, and this way is very nice, but I think the failure rate will be higher with more stones in number and in size. But I am totally agree with you that it is an option, and I mentioned it, but it is not present in my country. And a second point, that the failure rate will be higher, of course, in this case.
Dr. Hussein, and for this patient, it's not logic because she should go to India a lot. It's frequent sessions. I think surgery is better, but meanwhile, in such condition, she is in acute also stage. Will you change the stent, or you don't need, just to retrieve it of the pancreatic stent?
Check what?
Do you need to replace it?
The pancreatic stent.
Do you need to replace it, or just retrieve it?
For the acute stage, until they decide on surgery.
Yes, it may be blocked, but even if the stent is patent, to my mind, it would not prevent the recurrent attacks of acute pancreatitis, because the stones the number is very high. This is one of the few cases which I was astonished by the very large number of stones. You put the stent in the pancreatic duct, in the region of the pancreatic head. It is about 5 centimeter or 6 centimeter. What is the length of the stent? But in the body and tail, far away, there are many stones, and these stones will induce acute pancreatitis, especially in the presence of stents.
So you recommend for this patient surgery, no other solving. What about in this stage? She's in acute pain, and there are some edema.
Dr. Hiwa, we have a question from audience, please.
Yes, maybe the last 2 questions we may receive, and then we have to shift to for other
Professor
patients.
Dr. Ismail.
Yes.
I think ISWEL is a temporary treatment, as she mentioned, for this case, because the primary cause of this pathology will be there. And then ISWEL, this very sophisticated one, you should have very low shock wave energy for this type of stones. During the surgery, you can go by a flexible, thin endoscopy. You can clear the head and all the tails of the pancreatic duct, and then you can do the anastomosis. And this is a definite treatment. Otherwise, the shockwave lithotripsy will be a temporary one. And you can use laser.
Yes, I agree with you.
Dr. Ismail, I'm sorry for interruption. He's a consultant neurologist, so he may be the most one who experienced with the extracorporeal shockwave lithotripsy for ureteric stone or renal stone. We are now demonstrating, inshallah, in vitro, after third case, maybe a new cholangioscopy or pancreatoscopy, which is a Chinese one, Cesium cholangioscopy. We hope that we bring to our practice in the near future. This cholangioscopy is just like spyglass through the scope, which is 9 French cholangioscopy 4-wheel, just like spyglass. Very easy to manipulate. Although the company mentioned for 1 patient, but we can reuse for more than 1 patient. And if we can bring this cholangioscopy, do you think will be good for this patient doing pancreatoscopy and distracting the stones by laser lithotripsy?
If you decide to have
if the patient is still refusing surgery,
you should have the probe of electrohydraulic lithotripsy or laser probe. But to my mind, these patients will not benefit so much from electrohydraulic lithotripsy or laser due to the very large number of stones. You have at least 30 stones and all over the pancreatic duct. The shockwave lithotripsy will distract these stones into many smaller stones, so that you will find a large number of stones. So it will be a very tedious maneuver. You will stay distracting the stones and extracting the particles by basket for at least each session. It will take about 2 to 3 hours, and you will need 5 to 6 sessions. So this electrowave hydrotripsy through spyglass is very nice when you find 1 or 2 stones which are too large, or if there is a stricture, a stone after a stricture, so you cannot extract them by a basket. Here the spyglass and the electro is very beneficial. But here this is not the situation. Yes. The situation is you have a very large number of stones.
تفضل أستاذ مكي.
Line for the stones. Lithotripsy or intracorporeal laser distractions of the stones by laser, you should have a guidelines. Our guidelines, if it's more than 3 centimeters to 0.5, you'll never do it by laser lithotripsy, because it will not be cleared. It takes a long time. There will be a lot of morbidity for the patient.
You mean for ureteric stone, but for
it's a pancreas.
For our practice, if the stone about 5 millimeter or below 5 millimeter, we can easily remove by ERCP. If there is no dominant structure in the pancreatic duct,
yes,
between 5 millimeter to 10 millimeter, sometime by some expert may be easy removed through the pancreas. Not easy, can be difficult to remove from the pancreas. I think Dr. Taha he has more experience with this. But more than 1 centimeter or 10 millimeter, it's impossible.
More than 10 millimeter.
10 millimeter, it is impossible to be removed by ERCP without extracorporeal lithotripsy or spyglass induced electrohydraulic lithotripsy or laser probe.
But it is 1 or 2 stones.
Yes.
Not this large number of stones.
Question from Ustaz Maki, please.
The surgeon.
Sorry.
Hepatobiliary pancreatic surgeon, I ask you, after surgery, if pain recur, does a conservative therapy have any role in reducing pain apart from celiac block? يعني pancreatic enzyme replacement, PPI, medium chain triglyceride, does it have any effect in reducing pain, or it is?
It didn't. All these tools do not work with. Will not work with these patients because they has a definite cause, stone. This may work if we didn't know that.
I mean, they did surgery. Then after surgery, I noticed many patients, they recur again with back pain. Especially many of these patients, I noticed, they do not have pancreatic duct stone. They have calcification in the pancreatic parenchyma.
Yes.
And what we are assuming, this pain is due to increased intraductal pressure. But some of these guys, they got pancreatic calcification. And even after removing intraductal stone, after a while, then we have recur pain. Then what are the options apart from celiac?
Yes, I agree with you. But after excluding not excluding recurrence of stones. So you should do MRCP, you should do EUS, searching for recurrent stones or left stones. Not all stones will be removed. You may leave 1 or 2 stones. If you exclude the presence of pancreatic duct stones, then we can use other tools like pancreatic enzymes, crayon, pancreatic CPB celiac plexus block, not neurolysis, but after exclusion of a definite cause, which is recurrence of pancreatic duct stones or missed stones in this case.
Take a question from
Dr.
audience.
Amarjan, thank you very much. We'd like to thank Dr. Hussein, Dr. Takar Buli for this nice demonstration.
Thank you, thank you.
We will shift to other room, and Dr. Siva Hussein, she will present the third case. Please, for the shifting to other room. Thank you so much.
Thank you
very much.
Now we are continuing our live demonstration from Anwar Sheikh Hospital. The third case is an elderly female with long history of dysphagia for the last 11 years, associated with chronic cough. She underwent a session of balloon dilatation in 2011 with partial relief and temporary relief of her symptoms. Her recent barium esophagiogram showed mild esophageal dilatation with abnormal contraction and motility, but picture not typical for achalasia and small hiatal hernia. Finished.
And what is the diagnosis, please?
Dr. Aras?
Yes, Dr. Iwa. Yes, the same.
Dr. Umar?
The same point procedure.
Yes.
Dr. Aras?
Yes, I can hear you. Yes. Yes. Huh?
Dr. Umar?
Yes, I can hear you.
You hear us?
Yeah.
Okay, Dr. Sivan, she will present the third case, please.
She presented.
The third case is an elderly female with a long history of dysphagia for the last 11 years. She underwent pneumatic dilatation in 2011 with temporary relief of her symptoms and recurrence of her symptom now, which is progressive. Her last barium esophagiogram shows mild esophageal dilatation, but picture not typical of achalasia, and there's small hiatal hernia.
So it is not achalasia. Any manometry, Dr. Sivan? Dr. Hiwa, yes.
Within Dr. Amr, you can speak now. You have mic.
I have mic?
Yes,
yeah,
of course.
Do you hear my voice?
Yeah.
Okay, perfect. So good morning again. We are going to start the second case of poem with a spastic colon with Dr. Hiwa and my friend Dr. Madkour. We have here very good updated team with very well-equipped system. As we see here, we are shifting in the Olympus device to the TXI mode for the texture enhancement mode, and this is good to demonstrate the vessels in the esophagus and the mucosa compared to the normal white mode, and this is one of the special things in the Olympus machine. It's written at the upper right side of the machine. If we close it, this is the normal white balance, and if we press it now, we have the advantage to see more the vessels behind the mucosa. As you see here, the cardia is tight, not tight that one of the case before, but it's tight. And this is the stomach. And we do full examination for the gastric mucosa and the pylorus until we reach to the pyloric orifice, as we see here. And this is the pulp of duodenum. Here is some inflammation and a little bit diverticulum seen with ulcer in the second part. I think this patient had previous surgery here. No?
No, first history of peptic ulcer disease.
So as you see here, this is the diverticulum with linear ulcer with a little bit inflammation, course 3. And this is the second part of the duodenum, as we see, with good zonation and appearance of the mucosa and the villi at the second part of the duodenum. Now I will draw my scope into the gastric cavity, and we'll get some inversion to look about the cardia and the hiatus region. This is the fundus, and this is the cardia.
Your scope much better than the first scope.
Yeah?
Including regarding retroflexion.
Thanks for the recommendation. And now we will go back to do our calculations to measure where is the level of the cardia and the Z line. This is the Z line. The lower part is the gastric mucosa, the upper part is the esophageal mucosa. And then this is at like 37 centimeters. And we will go back to the esophagus, like 10 centimeters above.
Dr. Umar, Ustad Makki asking any associated hiatus hernia?
No, actually I don't see hiatus hernia at the time of assessment for the cardia after inflation. Now this is the position close right to, or at 5 o'clock there is the incision part. I need the needle.
So you start.
This is the vertebrae.
You want me
like 12
to assist you?
Yes, please, with pleasure.
Yes. I will assist them.
Yes, yes. We are together.
We are together.
Yes.
I have with me a very strong team at the backyard, Dr. Hiwa and Dr. Makur, and Dr. Hiro,
Dr. Marwan,
and Dr. Marwan, and Dr. Muhammad. Now we are trying to get the needle out and do the injection. Okay, going back, inject. This is very nice to see this split of submucosal injection. Inject, yes.
5.
And we are trying to be ready with the needle in order not to lose this injection before injection. Yes. Okay.
Yes.
Enough.
What's the volume you want to inject, Dr. Umar? What's the volume you want to inject?
The volume is 10 millimeters of normal saline mixed with methylene blue. But we could increase, depends on the your satisfaction with the elevation. Now I will shift to the TT knife. After injection and elevation of the mucosa. And as we see, the TXI mode is showing there's no seen vessels behind here. Needle out.
You prefer TT?
If I have it, why
TX,
not? Yes. And now we will do the first puncture. One of the good things here is that the TT knife is hooked into the mucosa. Okay.
Incision.
Yes, all these are the incision. And coagulation, we are trying to coagulate a little bit to widen the cavity of the insertion part to help for landing.
Let me say some tips here. As Dr. Amr he do the mucosal incision. Usually, this incision shouldn't be too deep, or you may cause a muscle injury. So usually it's a little bit superficial. So it didn't cut the muscularis mucosa. So to go inside, you have to cut the muscularis mucosa, and that's what he's trying to do now. After he cut the mucosa and started to see some mucosa, we will have a lot of fibers of muscularis mucosa still intact. He try to cut, then he can move to the submucosal space. Why he didn't go deep from the start and cut it all through? Because this is dangerous. You should cut mucosa and some of the muscularis mucosa, then you do what he's doing now. Try to expose the edge, dilate and cut the muscularis mucosa, then he can go to the submucosal space or third space, as we say. Usually we don't add
that you have a bleeder, Dr. Umar?
No, actually this is a very minor ooze from the blood vessel. As we know that the esophagus is a very vascular organ. As you see, this is the base, very nice scene. We could coagulate under vision. there is a small vessel here. We are trying to cut under vision.
And actually, usually these bleeding which may happen with the mucosal incision, actually it's usually capillary. So it's not significant, but sometimes it make you can't see well. So it causes some problems in the beginning, but almost it's not significant.
You see here, it's very clear.
And this is the muscularis mucosa we talk about. These white fibers. This is the muscularis mucosa. He have to cut, then he can go to the submucosa below. Dr. Hiwa, you want to say something?
Yes, I said even a minor bleeding when the scope got there.
Yes, it's like a compression. Yes. So sometimes you have a bleeding, it's minor, you couldn't detect the point. At this point, you may do what Dr. Hiwa said. You try to go fast with the scope to go inside, and then when you do this, usually it's controlled by the compression of the scope.
So we are trying here to widen the, still we do have here some fibers.
Yes.
We need to cut all these fibers.
Yes, it's very nice to demonstrate this, Dr. Amr, to show
yes,
the way to go inside.
I will need a little bit the needle out. Needle. Okay. As you see here.
Also, you're working around 20 centimeters, Dr. Amr, like I think from incisor.
Yes.
So you decide to do like a long tunnel because of the spastic nature of this patient. This sometimes makes the control of the scope in this area more challenging because you don't have enough space above you. And it's not easy to give a lot of down when you are very high lights.
Okay. We will try to enter the tunnel. Still, we do have some fibers not cutted, transverse, needle, yes. We could hook them from down to up and do the coagulation. The electric current,
I think we want to
it's
the isolation.
Pre-coag mode. Yes, because I don't see the transmission is okay. Now it's cut. Needle in.
Dr. Iwa,
connection is good.
There is no.
Yes, please.
There is no transmission, Dr. Iwa.
Of sound or video.
No, picture, video.
فيديو أنا مع جماعة.
Yeah.
كاك. No video.
Needle out.
Okay, let's go.
No?
I increase the effect to
the transmission is a little bit very.
I noticed Olympus generator underwater, the coagulation modality very weak.
Yes, this is true. And this is one of the
That's why we use endocut underwater to work better sometimes.
Dr. Arashe, está?
Transmission at all, almost disappeared.
Yes, Halikan.
In. That's why.
Try to fix it in the hospital.
Yes, within one few minutes they will fix the problem.
So they don't see what we are doing, right?
No.
This is complete down now. I'm trying to widen this, needle in, out, out.
Yes, underwater endocut will work better here also.
Faster, will be faster.
Yes, this is the muscularis mucosa. What he cutting now, these white fibers.
I'm trying to widen the spaces. The needle in. I will do some injection and inject these. Good. Okay, I'll try to.
What do you mean with sticking? Yes, down or reflex and leading, but he should cut these fibers. That's what we're trying to do now.
Make the first entry very important.
Yes, usually this is the most challenging step to go inside. So it's okay, no problem. Then more easy.
Okay.
It's better, but he tried a lot of techniques. So now it's difficult to go inside, so he tried this technique. So it may work with some patients, you don't need with other patients. You master many techniques and you use what you feel it's better to use. Usually coagulation needles work very well, so he used conductivity, and usually if it works saline, it
Dr.
works well, but if it's saline, it works good. No, I don't think so.
Dr. Aras?
Yes, not yet. The video not yet.
Okay, kam kamera sabta kan. Na bika na ewe, eraman na ewe. Awan video kaya? Okay. Video now?
No video. No video.
Okay, within 1 minute we will fix it.
Okay.
بداخل يكك لكان من كان ما يعني لو أنا من ضمن خاصة بواريك أنا وأخلي لك ما ندرس كله. سوري.
ديار بوكي برجولان هو.
هاي تبتوز قلوبين. That's قربان.
No, in fact.
This is the fiber we talk about.
Do you think you need to enlarge your entrance slightly? Yes, I would like to do this.
Came back the video.
Okay, you have. So you
came back.
Okay.
So you didn't miss a lot.
So you are now carrying out the tunnel, cutting the fibers.
Yes, no, entrance, entering to the tunnel.
Yes.
We are entering the tunnel, as you see. We're trying to give some water for filling the tunnel and the gap. And now we are in. This is what we call landing. The same steps as Dr. Matkour have done. We are turning down back the scope to get the muscularis propria down and the mucosa upward. And as you see in the TXI, the fibers, the white fibers is very well seen, needle out, yes. So we could start to do some cutting underwater. This is, I'm fascinating with this technique, but this is needle out, please, Dr. Hiwa. Sir.
It's inside the hole, there is some talk.
Now we are inside the tunnel.
Lower
there
down
is,
your
some coagulum. This is a coagulum from part of the coagulated mucosa. We are trying to stabilize our position. And now we will do the recurrent coagulation. I feel that the electric current is a little bit weaker than with Dr. Matkour. Do you agree with me, Dr. Hiwa? It's a little bit...
So you need to clean the needle?
Yes, close the needle and take this out. We will try to remove the coagulum. This is very nicely seen here. As you see, we are still at the edge of the tunnel. These wire fibers of the submucosal layer.
Please, we need the hole to be calm, please.
The muscle propria, the needle already here. Yes. And the upper part is the roof of the mucosa.
You do all of your procedure with the TXI?
No, we are not needle increase. Okay. No, we are not like fascinated like this, but if we do have this, why not? You could use it. It will be very nice for better demonstration, especially with the injection in the midstream blue. Needle out. What?
Agar zahmadni yek tos, we need quietness and calmness during the session, please. Thank you.
See, it's not
connected well.
Yes.
Maybe we need to change this.
I will try.
What do you think now?
No, this is the endocut.
We want another one.
No better, I think.
Did it work slowly?
It's not working with it.
We will change the paddle.
Okay.
So sometimes you have some small technical problems. It affects here. It's important to know how to detect and imagine where is the problem and how to manage it. That's what we do.
You see, Dr. Hiwa, when you are trying to cutting. So
they are now changing the.
Okay, so we will wait. So I would inject, please. More blue. When you see the blue color or the blue gland, this is very nice because down is the muscle and upward is the mucosa, and the blue color means that we are in the correct third space plan. I'm trying to widen the space after needle out. So we will try now. Still there is the...
Is he not connected yet? Okay. Really connect? Just a second.
Smile.
Now? You can
Perfect.
try?
No.
Not yet. The connection is very important to improve your setting.
Okay.
When you are getting familiar with the speed of your scope, sometimes you will feel some differences. Should I try?
Yes.
Okay, we will do this now. No.
يعني صوتك ايش مرة صجارن بيوتن.
Right?
Yes, now okay.
Now it's good. Yeah, this is the.
Sorry for a technical problem.
No, this is good. This is daily practice points we have to consider.
Everywhere. It happens everywhere.
So now this is the tunnel, and we are inside. We are trying to inject to get inside the mucosa. So injection. When we are injecting, the needle should be in. Dr. Hiwa, injection. Yes. Good. Then I will go.
Dr. Amr, where are you exactly? Close to the cardia, gastroesophageal junction, or not yet?
No, not yet. I'm far away from the cardia. Needle in. I'm far away from the cardia, and we are trying to work for the dissection at just like 2 centimeters from the incision.
So we have this technical problem. It takes some time to have a sufficient current. These patients, this is what we call the tailored myotomy. We talk that we can do a tailored myotomy. So let's say in Arabic, احنا بنفصل المyotomy according to each patient. It's a tailored, yes. According to the requirement of every patient. These patients have a lot of spastic contraction in the whole esophagus. So it's type 3 or GE junction, narrow area.
Yes.
This narrow area, actually, because of the spasm, this adds some difficulties while he working. And again, he tried to be in the center of the tunnel, follow the circular muscle, as we usually say. You can see down there is the circular muscle, and he tried to follow to be perpendicular to the circular muscle while he worked.
As you see here now, the transverse fibers of the circular muscle is well seen. I'm trying to go as mentioned. There is a small vessel here. We could dissect it with coagulation. Now it's turned white.
Yes.
And then cut.
Actually, spray coag is a very strong current. This is the benefit if you know how to use. As you can see, usually in the whole esophagus, we didn't need to use coag grasper. We usually use only spray coag. It can deal with most of the vessels in the esophagus. But you shouldn't be close to the mucosa, not to have a transmitted thermal injury while you're doing this. And what that's happening here, we try to be close to the muscle, and he do a repeated injection.
Okay.
If any questions, we can discuss while Dr. Amr is working.
Dr. Aras, do you have any question?
Injection.
So we can answer all questions during the procedure.
Okay.
And then
If there
after
is
the
any
procedure,
question about the procedure, we can.
About third space, about how to do, how...
Anything.
Doctor, if it happened that you need a lot of coagulation, does this had any late complication?
Literature say no, but in my practice, if you need a lot of coagulation, that means you have a lot of vessels. You may have a lot of bleeding. You may spend longer time in this. Actually, it's not related to the coagulation, but it's related to the cause. You need a coagulation. So if you have a lot of bleeding, a lot of long procedure time, you may have more incidence of acid-related, of gas-related complications, and you may have more incidence of infection. Not related to the coagulation, but to the cause, as I say. I can give my points. I use a lot of coagulation if I have a lot of vessels, a lot of bleeding. That means I spend more time in the procedures. I may have a lot of bleeding to control. This may have some special situations. So we have a longer procedure time, so we have longer acid, gas-related complications and the high incidence of infection, but it's rarely happened in bone.
Dr. Amir, Dr. Madkhour, what are your parameters of a successful operation? Successful point.
Okay, so parameter of what? So we have what's called the Eckert score. We all know Eckert score maximum score is 12. So we can say we have a clinical success. That means we have an Eckert score 3 or below. So it's equal or below 3. It's a clinical success and it's a continue. And before it was like 90%, the new data says like 96% patients who do PO, they have Eckert score 3 or below and continuous for it. And this is the clinical success. For the technical success, that means we can do the procedures and we finish with no complication and the patient go home. This is almost 100%.
So it's a mixture of subjective improvement and objective improvements.
No, it's a score. Actually, this Eckert score improves just once you let the patient drink. He can drink. He don't have a vomiting, and the chest pain improved lately, not so fast. But we couldn't assess Eckert score objectively, except after 3 months to assess the weight loss. And then in our protocol, when we do follow up after 6 months, we do again upper endoscope to rule out any reflux esophagitis and any spastic segment, and we repeat the manometry. So you can find in the manometry the higher number going down. So this is very objective, and actually Eckert score, I think, is the most important. Some patients are tricky, who still have some symptoms, especially with largely dilated esophagus. These symptoms actually don't relate to the procedure or related to the spasm of the cardia, but it's related to the size of the esophagus.
Ustaz Madkhour, we take a question from audience, please.
Okay, so in those patients, very important. You can see what is happening here.
Very rare complication.
Very rare, but happening. The cap is down. Go back to front.
Ask your question.
You can see this.
Okay. Can balloon dilator be used for submucosal dissection?
Dr. Aras.
Yes.
Please listen. This is sorry, but we have a very rare technical complication, which usually happen very, very rarely. But we are lucky that you will get this complication, but not the major complication. The distal cap is lost from the scope.
Yes, the transparent distal cap dislodged. Yes.
Yes. So we deal with like a foreign body. So I'm trying to hold.
I'm trying to
pull
get
back
very closely to the mucosa. trying to get it very closely. We'll use the irrigation.
So we are ready for your questions until Dr. Amr try to fix this.
Okay. You are ready, please?
Yes. Yeah.
Dr. Soros, ask your question, please, to Dr. Amr. Mike.
No problem. I put the plaster down. We need to remove the plaster here.
I have to dry it.
Yes. Yes. Now Dr. Taha gave a very nice comment. Dr. Taha asked about endoflip.
Give you more objective assessment of the success of the procedure.
Yes, it's a real time. Now, so sometimes he do endoflip before the procedures, and then after he finish the myotomy, he do endoflip again. So you are sure that the pressure is down, no segment is spastic, and then you are sure you do enough myotomy. But it's not available in Egypt. I'm not sure if it's available.
Ustaz Mathkour, we take a question from audience, please.
I need to
yes.
From Dr. Soros. Yes, Dr.
Show me the wash.
Can balloon dilator be used for the submucosal dissection?
No.
Fitting
you know, actually, what you say, it's a very nice question.
Okay.
But this was a historical point. In the beginning,
should we need to fix it with a...
Yes, I will fix it.
Asian Institute, Dr. Mohan, he mentioned that after he do the landing in the submucosa, he add a CRE balloon and he do dilatation and he go, but this is very traumatic, very aggressive, not sufficient, and it may cause bleeding. Those are not a problem. You don't have to do this. If you can do point, you will do like 20 minutes, you will be near the cardiac. So you don't need to do this. And there was a nice article published in the GIE, video GIE, like few months ago, but they use this balloon to control the bleeding. They have an arterial bleeding while myotomy, and they put in the control, and they place a balloon, and they do the inflation of the balloon, and they control the bleeding. Actually, I discussed the one who published this about this. I tell him why we don't cut the muscle. He said, now, actually, when we do myotomy, if we have a bleeding, a very nice thing to do, continue the myotomy for like half centimeter, then you have a nice exposure of the vessel. The problem when you cut the vessel in the beginning of the myotomy, the vessel is retracted below the muscle. You can't see, and you can't coagulate. But if you continue and cut the muscle for 1 centimeter, you can see the stand of the vessel and coagulate. And I think this is the best way. But you know, they published to show that may happen, and it was accepted in GIE. But for dissection, yes, and to establish a tunnel, we didn't do this.
Okay. There's a few vessels here.
So
now we are
this is a nice tunnel.
Yeah, this is our landed tunnel. It's like lower part is the muscle, upper part is the mucosa, and in between is the submucosa with a little bit some air bubbles in between. And we are trying to coagulate a little small vessel at the left side, and then we will complete our submucosal tunnel dissection until we reach. Actually, we did here a longer tunnel, as Dr. Mathkour mentioned, needle out. I will coagulate this point, as you see here, close to the muscle. It was like just an oozing point. And then we will accomplish the dissection. As Dr. Mathkour mentioned, this is a longer tunnel because the patient has a spastic esophagus, which requires a longer tunnel to cut more muscle, which is controlled or tailored as mentioned before.
So any more questions? We can discuss. We have a good time for discussion.
Can you do this procedure without CO2?
No, Dr. Taha asked one nice question. We say that in the last session. If we do without CO2, we are killing the patient. It's never to do without CO2. If you have a problem with CO2, postpone your patient. Don't think you are very good, you can finish very fast, and do without CO2. If you do for few minutes, you may have a severe complications. Sometimes it happens while we're doing this tunneling, we found some leiomyomas. Usually it's funny. but sometimes we find small leiomyoma inside the tunnel. We have like 3 cases like this.
Dr. Amr,
it's small, so it didn't get me.
I'm sorry, the assistant should not ask, but
No, sure, you are expert.
What about aberrant muscle? Sometimes you see longitudinal aberrant muscle.
I think it's here.
Yes,
you can
like
do
this.
from that why Dr. Hiwa asked, because he's an expert in this procedure.
See this?
Yes, it's like a longitudinal muscle over the circular muscle. You do nothing. You just continue, and you cut while you're doing the mouth. It's not a big issue.
Yes.
What about if we go sometime in severe case post-hilar, we did in few cases post-hilar myotomy, we end into intramuscular tunnel. We go, we see ourselves, we are inside the muscle.
Yeah, very nice question, Dr. Hiwa. So this is a technical question for friends who want to start doing this. In the first case, at certain point in the cardia, we cut some muscle, but we detect this and we go back and try to find our plane. Yes, you try to be very close to the muscle, but you should be aware you don't go inside the muscle, except if you wanted to do this. Sometimes you decide to go intramuscular, but if just it's very tight and try to cut the muscle, you go inside the muscle without realizing this. This may increase. Yes, we have a nice view here, First. Yes.
For a vessel rising from the muscle layer down, always the vessels are coming from the muscle up to the mucosa.
It's a penetrating artery.
It's penetrating artery, yeah. Needle out, Dr. Hiwa, and we will try to do the boiling effect. As Dr. Madkour mentioned, we could shift to the soft.
And you can see how Dr. Amr deal with this, because it's like a tree. If you have a tree and you have 2 branches and the 2 branches and the 2 branches, if you wanted to cut, you should cut from the origin. So you didn't deal with the upper parts. You just deal with the base, and then you control everything. And you give some space above the muscle, so if it's bleed, it's not retracted inside the muscle. Like when you do some polypectomies. Yes.
Ustaz Madkour, Dr. Abdullah has.
Yes.
I ask if you modify your approach or your technique according to the manometric type of achalasia.
Sure.
Yeah.
This is the great benefit of POIM, I believe. It's a tailored myotomy according to every patient, not only every type of achalasia. So for type 3, we do a very long tunnel. For type 1, we can do a shorter tunnel. For type 2, we do standard. But we examine every patient. So I have, maybe later we show this when we meet again, have a patient with type 2. It's fine, but just above here, just below the upper esophageal sphincter, she has a spastic segment. Actually, this is her main complaint. If we didn't cut this spastic segment, she will not improve 100%. And I have some patients who do a very nice hemorrhagiotomy, and the cardia is totally open, and a nice ramp, as they are type 3. So the myotomy was not long enough. So they have a problem of chest pain. They have a recurrent chest pain and feeling of food impaction in upper esophagus, which release. Then we go and do shorter tunnel for them for this spastic segment. So you always tailor your myotomy according to each patient, patient by patient. You do endoscopic examination before you start, then you decide when you start the entry of your farm.
I think this may be advantage of POIM when we have many cases of mixed picture. This patient with feature of diffuse esophageal spasm and probably type 3 achalasia. This surgery very difficult to
I'm not a surgeon, but I think they need to do thoracotomy or do something to do a very long myotomy like this. Maybe it can be done, but again, usually we look for the minimally invasive. Hilar myotomy, I think it's minimally invasive if compared to open surgical myotomy, and the POIM is less invasive as compared to a hilar myotomy, not because we are gastroenterologists, because this is the technique. So if surgeon can do this, I think he will not do hilar myotomy. Because I have some friends who are surgeons and do this procedure in the state, they say we stop to do hilar myotomy after we learn the POIM.
You had the questions?
So the next step is to learn the POIM.
If it happened and the POIM failed, can you redo and when?
Yes. Let's say, actually, it may happen. It's reported, but why it happened? Will happen if you didn't have enough myotomy. If you didn't go here, beyond the cardia for enough distance, but it may happen in the beginning of learning curve of some friends. They are not sure, they have some complications he didn't complete. If that happens, actually the recurrent symptoms take a long time. You can see in the first case, before we doing the myotomy, the cardia become lax. So even if you didn't do the enough myotomy, the patient will go for 3 to 6 months. Usually we see this. So if you have a recurrent symptom, and we are sure it's because of recurrence of the spasm. So we do the manometry, we have high pressure, and we do with the endoscope, we have a spastic segment, and we do barium, because the decision to redo, we should be wise to choose this. But if he need to do, we can do repoint. The guidelines say if he have a recurrent after point, he can do point and he can do balloon dilatation. Usually, we do few cases of redo point done in other centers, and we do repoint. Yes, these are the technical point. Dr. Muhammad say how to do repoint. We can talk about this. I think Dr. Hiwa also did some repoint.
One case of failure of poem, posterior poem, we did anterior poem.
Yes.
One case, but which was she improved clinically. She's very well after.
Yes. So we can do repoem, and if failed the hilar myotomy, we can do poem and we can do balloon dilatation. No solid recommendation in the guidelines in the redo. In our practice and our experience from abroad, from Chinese center where we have been trained, we do repoint for all these cases, and when we do, we have a very good response. If the problem was insufficient myotomy.
So you need to change. So you need to change the approach in the redo poem.
Yes. So this is the point Dr. Muhammad asked about, and what Dr. Hiwa say. Actually, we can go anterior instead of posterior, and actually sometimes I do in the same posterior, but I go a little bit back and make sure I go above the spastic segment, and I can pass the fibrotic part. It needs some experience, but you can do. And as we see, when we have the spine, we can go to the right of the spine or left of the spine. If you can detect the incision point, you can go to the other side, and you can go anterior. It's up to you and what you prefer and what you like more.
After a few minutes, we may shift to other room because of the...
Dr. Hiwa?
Wanted to say, ask a question, then we go.
Yes, please.
Ustaz Mazkour, we have a question from audience, please.
Dr. Hiwa, please, can you ask a question, Dr. Omargian?
In Egypt, do you have endoflip technique for the assessment of the esophageal motility? And do you recommend intraoperative endoflip technique for assessment of the effectiveness of BOEM intraoperatively?
It's not available in Egypt. If it's available and it will not add a lot of cost on the patient, for sure we will use, because it's very beneficial. But we believe if you follow the steps we say in the morning, and especially the anatomical landmark after the myotomy, if you can see the peritoneal fat and you can see diaphragm, and you can see all this, you are sure 100% you do enough. And if we have a small scope, pediatric scope, we can do double scope technique. Also, it's more objective. So we can use every technique that's available to make sure we go. And this is very important. Again, our aim not to do a tunnel. We don't aim to do a tunnel. We aim to do a sufficient myotomy. The tunnel is just the method which enable us to do this. So we should be sure we do sufficient myotomy, spend all time, do all facilities, because we shouldn't have our patient back to say we need to go 1 or 2 centimeters, and we failed because we didn't go enough.
Dr. Madkhour, Dr. Umar, have you ever practiced this procedure for other esophageal problems like spastic disease of the esophagus?
Yes.
Actually, this is case like this.
This patient.
Actually, this patient is spastic disease of esophagus. And this, you can see, hilar myotomy is a good option. BOEM is a good option. We can debate which is better, but both are fine. Both are okay. Both are within guidelines. But for type 3 and spastic esophagus, we shouldn't do hilar myotomy.
We did one case with jackhammer esophagus.
Yes, all these
dramatic response.
We should do both. We shouldn't do hilar myotomy because it will not be sufficient. The patient will not improve. Chest pain will not improve.
And this is one of the advantage for the pH high resolution pHmetry to discriminate and differentiate between any combined pathologies. And this is exactly what we meant with a tailored myotomy for the cardia and esophageal muscles.
We have a question from Dr. Mujda.
Very nice job. Congratulations. I am Dr. Mujda Rashan, surgeon. I have got an idea and a question. The idea of POM is to separate the submucosa from the muscle. So my question, and you are doing a longitudinal incision from above downward, but can you do from below a multiple injection from below to above, and after that to start dissection by using argon or low pressure water jet? Is possible?
Actually, all these are nice idea, and I won't say surgeons, when I discuss with them, they usually have an innovative idea. So this is a nice, we use when I have a very difficult sigmoid esophagus. Sometimes you lose your way. So one of the tips we do it, we start the injection from the cardia upward. So it acts like a guide for me. And my mentor in São Paulo, Professor Paulo Sakai, he doing this. Usually he do injection from down up, but I don't believe we need to do this, except it's like a salvage therapy if you need some other technique to solve some difficulties. But it's not the standard, but it's a very nice idea. Usually, Dr. Hiwa, surgeons have a nice idea.
Yes,
because they are innovative. By the way, all these techniques are invented by surgeons.
Yes.
Dr. Inoy is a surgeon, Dr. Zhu is a surgeon. So usually they give the idea and we did.
Thank for them.
Dr. Madkhour, another clinical question is that, you know, gastroparesis is not an uncommon disease. Have you practiced this procedure for gastroparetic patients?
Yes.
How frequent?
We do a lot of cases. Yes, we do a lot of cases of gastroparesis, and we do GPO.
The outcomes?
Actually, the result is not like POM. The literature say the response is like 70%, and you report from Dr. Khashab, who invented this technique, talk about 60%, and I believe it's between 60 to 70% in idiopathic gastroparesis and diabetic gastroparesis. So the response is not like POM, but for post-surgical gastroparesis, it's excellent. So some patients who do like a nasal fundoplication or do distal esophageal surgery, they have a vagal nerve injury and they have a gastroparesis. All patients I did post-surgical, they have excellent response. So it also depends on the etiology of gastroparesis. If it's idiopathic, it's autoimmune, it's a diabetic, the response not more than 70%, it's between 60 to 70%. For post-surgical, response is more than 90%, up to in our series 100%.
Yes. But still the result of G-point better than other modality, including electrical stimulation or surgery.
Yes, as you said, the other option is surgery. Not botox, not electrical stimulation. If no G-point, it's surgery.
Please, we have a question from the hall. Yeah.
Okay.
We have a question from the hall. Question, please.
Yes, my question to Dr. Madkhour. While doing the tunnel now, if perforation is happening, what's your approach and what you can do?
Perforation for the muscle or the mucosa?
Perforation posteriorly or anteriorly?
Posteriorly.
Posteriorly.
Yes. This question is the answer. Because in third space, we deal with the GIT tract as 3 layers. So once we have 1 layer intact, we have no problem. So if I cut the muscle backward and I see the adventitia during the procedure, no problem as long as the mucosa is intact. But that will cause me a lot of problem. Problem why? Because the air will escape and it may cause some pneumothorax, cause some capnoperitoneum. So the peak will be high, CO2 will be high. So I have to manage this. Only to complete the procedure, and once I close the mucosa, we have done. But you always must keep the adventitia intact. Because if you cut, you may find yourself inside the thoracic cavity. It's never happened. I don't see reported except one case who doing stair. So he need to cut, then he fall in the thoracic cavity. But as long as you keep the anesthesia intact, no problem, and you deal with the gas-related complication in cooperation with our anesthesia.
Problem, so you have to.
And if we have a mucosal injury, we close after we finish the procedure. We finish the procedure, then we close all mucosa.
So you mean in third space endoscopy perforation mean mucosal injury?
According to what we're doing?
Yes.
Yes, in tunneling, it's a mucosal injury. In ESD, maybe muscle injury, you always should keep one layer intact. They are not one layer, they are 3 layers. Mucosa, submucosa, and the muscle layer. As long as you keep one intact, you don't have perforation, you keep the integrity of the GIT thread. I think Dr. Amr do a nice job now. He reached the cardia, but he didn't pass the cardia yet, and he will work again from the tunnel to pass the cardia.
So, Dr. Madkhour, keeping the mucosa intact because it is the only barrier between the lumen of the esophagus and the mediastinum.
Yes, yes, yes. So this is the concept here. This is the right, a very nice point. This is the concept. Here, the barrier is the mucosa. I will cut the muscle in the end. When I finish the procedure, I will do myotomy. I see the adventitia. I see the mediastinum. I see the peritoneum. I see the diaphragm. The only barrier is the mucosa. If the mucosa is injured and I go with the scope out, I will find some rice and some milk near the lung and the heart when the patient eats. So I can have a mucosal injury, no problem, but I should detect and close before I send the patient home, before I go with the scope out.
Sorry, Dr. Aras, for interruption. Ustad Ahmed, we will go shortly to the other room, and Dr. Sivan, before this, she will present the other case in the other room, and then we will shift from this room to other room. Okay. Please stay with us.
Okay, okay. Madkhour, one question. Is there a trial doing this procedure in pediatric congenital pyloric stenosis?
Yes. Pyloric stenosis according to the age. Okay. I don't read any literature done for like baby who is less than 1 year, but some patients are late onset, or diagnosed late onset. So we can do. I have one case like this. But I don't think it's in a few months we can do. I don't know. I don't think there is anything in literature. I think like congenital pyloric stenosis is diagnosed very early.
Okay. What about adult megacolon, adult Hers spring? Have you practiced?
Yes, yes. We have called the PRIM, Dr. Hero talked about before. A few cases are done all over the world. It's not yet a standard of care, but it's an option to try, and the patient should know it's not the guideline yet. Not like foam, it's not trial, it's a guideline. But for PRIM, it should be, the patient should know it's a new technique, and he may benefit from, but it's not the guidelines.
The outcome was satisfactory?
I didn't do any cases. Dr. Amol from India and Dr. Mohan from India, they do most of cases and they say it's effective. Now we can go to the other room, right? Yes, we go to the other room, then we wait you back.
Okay, Dr. Sivan, you can start.
Back. I want to inject.
Female with no history of diabetes and hypertension, presenting with 3-week history of abdominal pain and jaundice. During her workup, she has elevated ALP of 389 and elevated CA19-9 of 222. Recently, she underwent ERCP, which shows mid to distal CBD stricture and plastic CBD stent deployed. So now we'll shift to USFNB done by our professor, Dr. Hussein Okashi.
Sivan. Dr. Sivan.
You can see these procedures are only advanced and should be done by expert endoscopists because every patient is liable for a complication which can be managed only by experienced endoscopists. So hopefully now we'll be able to transmit to the operating room.
Sivan, we didn't hear the history well. We didn't hear the history. Yeah?
Okay, I will repeat. She's a 68-year-old female.
Yeah.
Yes. Known history of diabetes and hypertension.
Yeah.
With 3-week history of abdominal pain and jaundice. With elevated ALP and CA19-9. She underwent ERCP recently on June 2023, showing mid to distal CBD stricture and plastic biliary stent deployed. So now the plan is US FNB from the CBD stricture.
I see, thank you. So the case is now clear. They will take endoscopic ultrasonographic FNB from a distal CBD stricture.
Okay. Bismillah ar-Rahman ar-Rahim. Do you hear me in the home? Okay.
Yes, Dr. Taha. Yes, the sound and the video, both of them are okay.
Yes, okay.
Yes, okay, sir. Yes, you can start.
As you hear from Dr. Sivan, this is an old lady with history of obstructive jaundice and distal CBD stricture, mid-distal CBD stricture as described during ERCP, and a plastic stent was inserted. We start now examination from the mid-second part of the duodenum as the site of the plastic stent. Now we are examining here. The papilla is very nicely seen. Yes, this is nicely seen papilla. And I think this is the beginning of the common bile duct inside the papilla. Yes, we will start to do anti-clockwise rotation. Yes, anti-clockwise rotation. Yes, there's very nicely seen common bile duct because this is the plastic stent inside. This is a plastic stent inside. It is the sign, equal sign, the sign of equal, or the tram lines. So this is the plastic stent. So this is the common bile duct. And this is the papillary region. And this is the muscularis propria of the duodenal wall. We start to do more anti-clockwise rotation and slide down. Yes, this is the CBD. And here, this is the pancreatic duct. So this is a double duct sign, dilated pancreatic duct, very prominent. Yes. And this is the CBD collapsed over the plastic stent. It was dilated before. Here I'd like to put a color flowed signal. Yes, this is the CBD not taking signal. This is the pancreatic duct not taking signal. And here this is mostly, it will be the superior mesenteric vein because we are now very deep in the duodenum. So this is the site of the superior mesenteric vein, and I think this is anatomical site of the gastroduodenal artery. To be sure, we apply pulsed wave. Yes, pulsed wave. Yes, this is a venous structure, so it is a superior mesenteric vein, and this, yes, arterial structure, so this is the gastroduodenal artery. Now, till now, there is no masses at all. It is normal pancreas. But here there is a grave sign, a very dangerous sign, which is dilated pancreatic duct. Common bile duct, it was dilated before and now collapsed over a stent. So we will keep on examination, anti-clockwise, yes. And here it starts to appear a large mass. Yes, this is a very large mass, not very large, but it is classic irregular mass. This is an extension here, extension there. This is, of course, a malignant-looking mass. It is not small mass. It is about 27 by 29 millimeter, about 3 centimeter. Okay.
Where is located, Ustad Ukasha, where is location?
Where is?
Where is located that mass?
Located
exactly.
in the mid-second part of the duodenum, at the level of the stent. As I told you before, we are now in the mid-second part of the duodenum at the level of the stent, so we can see the stent very nicely at the papillary region, and we are keeping up in the upper second part of the duodenum with a slight anti-clockwise. So this is very nicely appearing pancreatic duct and superior mesenteric vein, superior mesenteric arteries. This is the classic appearance in the mid-second part of the duodenum. We'll keep going up very slowly, anti-clockwise, and slide down. Here we can see a large mass. So this is a large mass in the pancreatic head. Now, before taking a biopsy, we should do staging of this mass. Is it resectable or not? Okay. So this is the mass, and I think this is the pancreatic duct. Okay, this is the gastroduodenal artery. It is away. The most important is the superior mesenteric artery and the superior mesenteric vein. Yes, this is a vascular structure. I should apply pulsed wave Doppler. Yes, this is very nicely seen common hepatic artery. This is the common hepatic artery. Here there is a contact between the common hepatic artery and the mass. This is the line of contact.
Yes.
But it is, I think it is clear line of contact. This is the common hepatic artery, and this is the mass, and here this is the line of contact between the common hepatic artery and the mass. So it is not encasing, and I think it is away. And this is the pancreatic duct, not taking any signal. I will keep examining here. Yes, this is the superior mesenteric artery. This is, I think, the superior mesenteric artery. It is away from the mass. So the mass is away from the superior mesenteric artery.
So,
and here I think this may be...
Ustad Okasha, so the most important EUS evaluating marker for resectability is to evaluate the vessels.
Yes. So we are now...
vascular invasion or vascular infiltration.
Yes, exactly. Yes, the most important is vascular infiltration. So now it is in contact with the common hepatic artery, but here there is a very clear line of interface, so it is not invading the common hepatic artery. There is a clear line of interface. And here this is the superior mesenteric artery. It is away from the mass. Now we would like to know its relation with the venous confluence, with the superior mesenteric vein, with the superior mesenteric vein and the venous confluence. Get up, trying to identify these vessels.
Dr. Aras?
Yes.
Sorry, Ustad Dr. Hussein.
Yes.
Our team in other room, they will do myotomy now. They will do myotomy. We go to the first room.
Dr. Iwa, we already saw the myotomy.
Yes.
I think the audience wants to see this USFNB better.
بكن بالتصويت زانا لنتي.
أما تاني أبشينو ببوي مكا. كيف خوتا؟
ألنتي.
والله بس دكتور محمد جوابي وأنا أدري كان جوابي أنا.
زو أقرأينه ولا تان. Just few minutes. Because it is very interesting, because they will do long myotomy, because the patient is spastic.
I will not go on, and I will not do the FNA except if you come back to me.
Okay. We will see your procedure.
Alan, do I FNB ورقتنا شنو الرومكي كا?
Dr. Aras, we will go for the first room.
Okay.
We go for the first room. They will do myotomy because long myotomy. and then we go for the second room for USFNB. So please, Dr. Amr, you are online now.
Okay, okay.
So I'm now start the myotomy, starting with some
You
calculation.
see Dr. Aras, Dr.
No,
Amr?
no. Still, we are in the EUS station.
I'm you. Here. Dr. Aras?
Not yet. Not yet. Yes. Yes, it's shifted. Yes.
Dr. Aras?
Yes, shifted. We can see it. You can see it.
She found the book.
Dr. Aras?
Yes, I can hear you. You can see it. We are in the myotomy room.
Okay, you hear us now?
Yeah. Clearly.
Okay, Dr. Amr now he's doing long myotomy because the patient with spastic esophageal disease.
We are starting, as we see
yeah.
here now at the floor, we're doing selective myotomy for the rounded or circular muscle, and now we are trying to cut it here, going up. As you see here now, the outer longitudinal and the, inner circular and outer longitudinal muscles. Our longitudinal muscle at the back and the circular muscle are in the front.
So this is a
now we are doing, this is the circular muscle.
Full thickness.
I'm cutting it.
Full thickness poem.
Excuse me?
Full thickness poem.
Yes, full thickness myotomy.
But not here. We
But
will
not
do
here.
in the end, yes.
The
This
case,
is selective.
the case was
this is
not
here.
a genuine achalasia, Dr. Omar. Huh? This is spastic disease of the esophagus.
It depends on the length of the myotomy. Usually we do the full thickness 3 centimeter above the cardia and 3 centimeter below the cardia. Here, Dr. Amr will do like 22 centimeter myotomy. He don't have to do full thickness. It will not improve any symptoms. We just need to cut the circular muscle, but 3 centimeter above the cardia, 3 centimeter below the cardia, he will go for full thickness myotomy. And again, if you do full thickness from the start, it's not a big issue. It's not a mistake. But if for any reason have an event, prolong the procedure, if you have a bleeding and he need to stop, he take more time, that means he will have more time while gases escape to the mediastinum. So it may cause more gas-related complication. So we try to do selective myotomy and do full thickness myotomy before the cardia by 3 to 4 centimeters.
So I'm catching the lower part and hooking and then cutting up, trying to be cautious not to cut the opposing mucosal wall during this procedure. We coagulate at the first because sometimes we have a hidden vessels not seen in deeper in the muscle, and then cut. Going to hook needle out, please.
Sorry. We change.
We're going deep, coagulate, and then coagulation, going up, cut.
See muscle getting thicker and thicker more.
Yes, this is a good observation. You have an eagle eye.
Thank you.
So,
Dr.
coagulation.
Dr. Umar, may I ask, you know the achalasia patients or the spastic disease, the distal esophagus is usually aperistaltic. If you do full thickness myotomy, what will be the outcome? No more muscles.
No more muscles?
No more muscles to contract, to perform the peristaltic function of the esophagus.
But the disease in those patients are because of disease in the muscle contractility. We have a diseased muscle. That's why we cut.
This is like your ECG. When you have an ECG with the cardiac symptoms, you have to respect. If the electric signals of the high resolution manometry is telling that there is a lot of contractions, means that this is not a thick muscle, but they are doing a lot of contraction, which is symptomatic for the patient in the form of dysphagia.
Now you try to do full thickness myotomy, Dr. Amr.
Yes. Now this is, as you see here, this is the adventitia, deeper, and we are trying to be very close. This is a very long tunnel. Coagulate at the first and cutting. Actually, I've learned all these things from my brother, Dr. Madkour, because he was following the Eastern School. And there is a lot of tips and tricks I have learned actually from his profession in this thing. You see these vessels crossing back the adventitia. We have to be very cautious during going deeper and hooking some of them, coagulating, coagulation, and then cutting. Going further deeper, this is how we are doing. Hooking, coagulation, then cut. We are getting close to the cardia and of course the muscle.
Here you can see a nice view. Carefully go above. If you just push your knife and cut, you will cut this vessel. We was talking now with Dr. Marwan. He say some reports about one doctor who cut the aorta while he doing this. If that happens, that means he didn't know how to do poem or do it in the right way. That didn't mean one of the complications of poem, we can cut the aorta. It was very strange for me. So if you can do it in the right way, you will never do this. And again, it's a demanding procedure, should have enough training, and you should watch a lot. Watch, see a lot of cases, then you can see the variety and the variation, and you can have another plan. As you see in the first case, we have a challenging plan, so we do another strategy, actually first time to do. But we act posterior like anterior, so we can finish the procedure.
I think regarding training, we should do complete at least many hours on animal.
Sure.
And then we should try this procedure on human.
Sure. And I think you follow the same school, Dr. Hiwa.
Yes, I think.
You attend a lot of cases courses outside.
Yes.
And this is the right way. And if you do this, you will have a very good results. And you have a trust for the technique. Any new technique, you should gain trust of the people, for the doctors and the surgeons and the gastroenterologists. If you didn't do this, you couldn't blame them. So you should be well trained, have a good results, so you gain trust of the technique. For any new technique, endoscopic or surgical.
FNB, just maybe less than 5 minutes, we finish the myotomy and they will come to the other room. Dr. Aras?
Yes.
You see now there is some fats and serosa going at the adventitia. Down deeper at the cardia, there is a yellowish fatty appearance.
But I think not yet, Dr. Am,
This
right?
is the cardia, I think.
Yes, maybe down. We will continue until we see that fragment. I think the cardia is down. Yes. Dr. Marwan say a nice tip here when we do the myotomy, and this is important. And if you want to have a very low rate of reflux, you should do this. All surgeons know what is sling fibers. I just know when I started doing this. So sling fiber have a very important anti-reflux mechanism, and it's not related to the pathology of achalasia, so you shouldn't cut. So we should avoid cutting the sling fibers, so we have a lower incidence of reflux. So when we go to the stomach in this area, we should move to the right, so we preserve the sling fibers. What is right and the left? You can see in the cardia, we can move to the right 4 centimeters and to the left centimeter. In the stomach, it's not esophagus.
It's very wide.
So it's very wide. So we should be oriented to the right. So we should keep sling fibers intact. We shouldn't go more than 2 to 3 centimeters. If you do this, I promise you, you will have a very low rate of reflux.
I think we will shift to other room because the other room team are ready for USFNB. Dr. Aras?
Yes.
You saw very beautiful complete myotomy.
Yeah.
Now we go to other room to see the USFNB by our master, Dr. Hussein Ukasha and Dr. Taha Karbouli. Please.
Okay. We are attending.
Dr. Aras?
Yes, I am with you, yes. But still, the station is the myotomy station.
Dr. Aras?
Yeah. We got it, Dr. Iwa.
Dr. Aras?
Yes, I can hear you. Dr. Iwa, do you hear me?
Fix.
Dr. Aras?
I can hear you.
Dr. Aras?
Yes, I can hear you.
You see the ultrasound picture?
Yes, it is very clear.
Okay, Professor, and now we are ready for your...
Yes, they are now visualizing this position, very nice. This is the portal vein. This is the mass, very well defined from here to there and from here to there. And this is the pancreatic duct. And here this is very nicely seen superior mesenteric vein and superior mesenteric artery. And this is the aorta from which the superior mesenteric artery is rising. And here this is the common hepatic artery. And this is the gastroduodenal artery coming from the common hepatic artery. So this is very nicely seen. Superior mesenteric vein, superior mesenteric artery, aorta, common hepatic artery. We can confirm that by Doppler. Yes. This is the Doppler. Yes. This is the common hepatic artery. This is the portal superior mesenteric vein, superior mesenteric artery, aorta. And here this is the common hepatic artery giving rise to the gastroduodenal artery. So it is just abutting the common hepatic artery with clear line of interface. Yes, here. And the portal vein, superior mesenteric vein is away. Superior mesenteric artery is away. This is the common hepatic artery. This is a lymph node. And this is the dilated pancreatic duct. Okay. No color here in the pancreatic duct. Yes. Common hepatic artery, gastroduodenal artery, superior mesenteric vein, superior mesenteric artery, aorta. So it is T2N1 because there is lymph node, and there is another serious lymph node in the porta hepatis. I will go to there to take a biopsy. If we take the biopsy from the mass and the lymph node, it is better to start with the lymph node. But we are usually flushing the needle and flushing the echo endoscope with saline and then go to the other side. ناخد دلوقتي we'll do FNB. FNB is better than FNA. النيدل فين؟ lymph node first in order not to contaminate if the lymph node if you take from the pancreatic head mass first, mostly it is malignant. If you do lymph node after the mass, you can transmit some malignant cells.
Yes, that's the point.
From the mass to the lymph node. Vice versa, no. If they start with the lymph node and it is malignant, then nothing will happen in the primary because sure it is malignant. Okay. But if you take first from the lymph node, very nice. If it is malignant, then the first neoplasm is precursors. If it is benign, then it will also not transmit. I start here, but most of people start from this or that. But if you start first from the pancreatic head, you should flush the needle with saline and flush the echo endoscopic channel with saline. And then you can go. So you may do from this or that, but you should do flushing. Okay? Now I will concentrate on...
Dr. Taha, what do you think about the case? Could be primary cholangio or pancreatic duct?
No, yes.
Say pancreas, most likely.
Because CT scan, I mean, that's why I want to ask. Because imaging study by MRI and CT scan mentioned this is most probably cholangiocarcinoma.
Yes, it is very difficult to differentiate based on echoendoscopic picture. The only finding is that there is pancreatic duct dilatation. Pancreatic duct dilatation. Pancreatic duct dilatation usually do not occur with cholangiocarcinoma.
Yes.
Cholangiocarcinoma produce only CBD dilatation. But the pancreatic head mass and the papillary mass can produce double duct sign, can produce both. If you can't differentiate, never mind. No need to differentiate because the management is the same. I asked my favorite cytopathologist, could you differentiate based on cytology? He said no.
I see adenocarcinoma. I can't judge if it is cholangiocarcinoma or pancreatic head mass. And no need to differentiate. Even there is no markers by immune staining. Now we see it very nicely here, the tip of the needle going, I think, in the right place, and then we will remove the stylet 1 to 2 centimeter.
Ustad, you are transgastric or transduodenal?
Transduodenal.
Transduodenal. Yeah.
Yes. I am now in. It is a very hard mass. I am in now. It is a very hard mass. If it is so hard, I ask my assistant to fix the echondoscope, and I do a single push. Yes, now I am in very nicely. We will do slow. Yes, we'll introduce the stylet again inside, and then to pull it very slowly while I am moving inside. While I'm moving, stop. While I am moving inside the mass. Now I am using, this is the slow pull technique, low pressure technique, or capillary technique. Okay? Usually 2. For lymph node, usually 1 or 2, depending on the result of the first biopsy. If the first biopsy is convenient, then it is enough. Where is the need? Where is the syringe? You prepare it with negative pressure. Then this is the high pressure technique. He will fix the needle 20 milliliter air. Yes, we'll open it. Yes, now we are high suction technique, and to continue doing to and fro a movement for 20 times at least.
You prefer a negative pressure or just small syringe? Usually.
You mean a slow pull, low pressure or high pressure?
I mean, this is a 20 cc syringe with strong negative pressure.
Yes.
Or you use routinely this technique,
yes,
or
yes.
just small syringe and you aspirate by yourself sometime?
Yes, this is a very nice question. What I used to do, first slow pull technique. If I find blood comes, then I will not do high pressure. But if blood do not come, then I do high pressure. If blood comes, then the pressure is very nice, no need for high pressure. But here there is no blood comes. So I prefer to do low pressure technique and high pressure technique. Okay? Now I am moving inside the mass. Very nicely. This is the tip of the needle. Movement should be within the mass.
Akasha, the same tract, you go inside and outside 20 times, or you will change the needle injection site?
Yes, fanning, yes. I do this first and starts to do fanning. Fanning can be done by the elevator. Yes, now I am doing the elevator and the downward push of the big wheel. The big wheel is away from you. Now I am big wheel away from me, so I change the plane. This is another plane by downward movement of the big wheel and the elevator or lever, as we are calling it. So we are now doing fanning in another plan. Yes, and I think now we did it several times, 20 times, so I will go out.
Please let me see the syringe. The syringe content, if it's feasible.
Yes, here this is a syringe. Okay. After that, I will look at the puncture site to observe any bleeding. No bleeding, I think. Sometimes, every 10 case, we see what is called open track sign, bleeding along the track. But here there is no open track sign. It appears very nice. And then we go to each other by the camera.
We will put on the tube.
Yes, we'll prepare. We'll prepare for balloon block. And we'll prepare. Okay. No. I will style it. Can the camera concentrate on my hand? No. First I am put it in the slides. ممكن الكاميرا تيجي هنا. Style it. Finally style it. Put the stylet.
Let me help you, sir.
Yes.
Silent.
We are putting the stylet inside the needle to expel the material. Can we open the light?
Usually we use negative pressure for syringe, and you push. If the content not come, then we use stylet. What your approach? You directly use stylet?
We use the stylet first.
Okay.
And if it didn't expel material, then we use the needle. Okay, very nice. Nothing come till now.
Ina kaman boke slide kan. Or shushana.
Yes.
Slightly there is some resistance. I don't know why. Maybe too much content.
Mix straight, yes. Now it starts something not convenient yet, yes. Now it's coming.
Yes, now easy.
Yes.
Ustaz Hussein, which usually you use the 22 gauge needle?
Yes, 22 is the standard, yes. 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 Now we will put in formalin. Okay, yes. Now you see this is now coming a core, a nice core. Okay. Again. Now coming a nice core.
Twice.
Again.
You see, Dr. Umar?
Yes. We can see it. بس أو استيكرات وزينة أجر هالي جرت وشوكا هنا كنا على جبين أو بلاس.
Show it. Show.
أو استيكيكا بشوشة كوية. Just rotate-ika. إسا واضحة. Yes.
Okay, this is the final.
Yes, a worm like, yeah.
Okay.
Yes, I will show it to you. Air, syringe with air. Syringe with air, not usual syringe like this. And expel here, okay? And flush it with saline. Flush it the needle with saline, but very rapidly. Can you concentrate in this?
Yes, sir. We can see it. Very nice. Well done.
It's very nice, and it is not staining the formalin. You see, it's not staining the formalin. So it is not blood. If it is blood, it will contaminate. It will contaminate the. If now it's very nice. If it is blood, it will stain the formalin with red. I think this is very sufficient. You can see it here now. Nice. Okay. Now I will go up in the stomach to complete the staging. Now this is the local staging. Now this is the local staging of the mass, but there may be porta hepatis lymph node, there may be celiac lymph node, there may be mediastinal lymph nodes, there may be left suprarenal deposits, there may be liver deposits. So we should complete our job. Okay? I think you saw it finished. Then we should complete our job and complete the staging. Now I am preparing the slide. In my country, they like to do both slides and formalin. It's very nice slides now. And I fix it with alcohol. Here there is alcohol, 95 at least, 95% at least alcohol. 70% alcohol for sterilization cannot be used, should not be used, because it produces lysis of cells. So we use 96 concentrated alcohol. Now we have a very nice slides. We can concentrate in these slides. Now 1, 2, 3, 5, 6, 7 slides. So it is very nice, and I will use it. Yes, we can immerse it by alcohol. Now we will go up to complete examination.
Ustad Hussein, Dr. Aras.
Yes.
We will go just for 30 seconds because we want to wake up the patient in the other room just to see the final endoscopic picture after complete POIM procedure. Just for 30 seconds. Okay?
Okay, okay, go. No, he didn't take from the lymph node, just from the pancreatic mass. Now, you have to take from the lymph node, later on from the pancreatic mass. Well, he didn't take it.
Dr. Aras,
yes.
you see?
No, no, yes, yes.
Dr. Aras?
Yes, yes, we can see. Yes. Dr. Hiwa, Dr. Hiwa, we can see, yes, the video is okay. The video is okay.
Dr. Aras?
Yes, the video is okay, Dr. Hiwa. I can
Dr.
hear
Aras?
you. I can hear you. The video is okay.
Okay, great.
Okay, you see? Dr.
Yes,
Ahmad?
yes, yes, yes.
Okay.
So we
it's
finished
okay.
Our job and we closed the tunnel. As you see here, there is 5 hemoclips with good arm deep holding the incisional part of the mucosa at both sides. And now we are going to examine properly and thoroughly the mucosa of the tunnel. There is no any signs of thermal injuries. As you see, this is at the 6 o'clock. Now we are getting close to the cardia. I'm moving very cautiously in order not to push the clips upward. This is the deadline and the cardia is very lax. And now we are in the gastric side. Very importantly, we have to deflate some air and we will go back for second looks. So now the job is accomplished and hopefully this will meet a good clinical response. Thank you.
Okay, well done.
Thank you so much, Dr. Aras. Do I we go to the other room because we want to complete the US FNB and staging of the case by Dr. Hussein Kasha.
Okay, okay. Okay, go.
Ustad, you are online.
Okay.
Dr. Aras?
Yes, sir.
Ultrasound here?
Yes, yes, yes. Yes. The video.
Now we will continue examination of different stations of lymph nodes. Here, this is the aorta.
Dr. Aras?
Yes, Dr. Hiwa. The video is okay.
This is the aorta.
Yes,
This is the aorta. We are now about 42 centimeters from the dental arch, 2 centimeters below the cardia. This is the aorta, and this is the origin of the celiac axis. And below it is the origin of the superior mesenteric artery.
Dr. Aras,
Yes, yes, the video is okay. Yes.
الفلور معانا.
Yes, the video is okay.
You hear us?
Yeah,
This is the
yeah,
aorta.
yeah.
This is the aorta, and this is the origin of the celiac axis. You can enlarge this.
Yes.
And okay. Yes, this is the aorta. Okay. This large vessel is the aorta. Okay. And this is the origin of the celiac axis. And below it is the origin of the superior mesenteric artery, and below it is the left renal artery. So this is the major 3 arteries coming from the aorta. Here there are no celiac lymph nodes. But when I keep anti-clockwise rotation, this is the common hepatic artery coming down from the celiac axis.
Dr. Aras, pointer كيمن أو كبوي جولينم أو ما بس يوانية.
Yes, yes, I know.
Here we notice that a lymph node here above, at the bifurcation of the celiac axis. Yes, this is the bifurcation of the celiac axis into splenic and common hepatic, and there is a lymph node above. Yes, this is a lymph node here. So this is a celiac lymph node at the bifurcation of the celiac axis. But it's not, to my mind, is not very dangerous lymph node. It is flat, may be malignant, but may not be too hazardous. So we are keep, I think I thought, yes, this is another one.
This one is.
This is another one. It is a very serious one. This is at the arch of the splenic artery. You see the splenic artery? Yes, here. This is the splenic artery. And if you do pulsed wave, this is the arch of the splenic artery, very famous. Yes, this is the splenic artery. And here, this is a very serious lymph node.
Serious by the size.
Serious by many factors.
Oval shape.
Divide the shortest axis over the longest axis. We measure it. Okay. This is the shortest axis. It is about 10 millimeter. The longest axis. Longest axis. It is 19 or 18 millimeter. So divide 10 by 18. So it is more than half.
Sir,
so
would you go to take biopsy from it?
Yes, of course, sure. We should be, because if it is a malignant one, then it may make the operation. This is a second station lymph node. It is not a first station lymph node. So I should take it from this, because it is very, very suspicious.
Is there any calcification in the center, or hyperdense area inside the node?
Yes.
You
Let
can
me
see it.
complete. The hyperechoic hilum, I didn't observe very, very clearly the hyperechoic hilum. It is just a point or 2 points beside each other. So the hyperechoic hilum starts to be lost. It is just these 3 points. The third one, that it is echo-poor. It is black. So it is echo-poor, nearly lost hyperechoic hilum. The shortest over the longest axis is more than half. So it is a globular lymph node, not a flat or elongated lymph node. If we have elastography, it will be a very nice adding factor, but here we didn't have elastography. So I should take lymph node biopsy, because if it is positive, this is a second station lymph node, and according to the classification or staging of the pancreatic mass, many surgeons dissect and remove the lymph nodes. Peripancreatic, okay. Porta hepatis, okay. Celiac, okay. But if it is located left to the superior mesenteric artery, then it is a third station lymph node, and you should abort surgical excision. This is splenic, so it is to the left of the superior mesenteric artery. So if this lymph node proved to be malignant, then it is a very serious situation, and the patient should have neoadjuvant chemotherapy in order to treat this lymph node before considering surgery. So any lymph node for pancreatic head masses, for malignant pancreatic head masses, any lymph node to the left of the plane of the superior mesenteric artery, this contraindicates surgery, except after neoadjuvant chemotherapy. This is a splenic, very nicely seen, very nicely seen.
It is not usual, this lymph node to be positive.
This lymph node, yes. So we should take a lymph node. Here the lymph node is a little bit, will be more difficult, because taking biopsy from the stomach is a rather bit more difficult. You can fix the echondoscope. Why? Because it is mobile. The duodenum, the pancreatic head is fixed in the retroperitoneum. But here this is intraperitoneal, so it is mobile. We may use the door knocking technique if we need. Then first, the patient is awaking. Well, now it is anesthesia. And here, I will push it a little bit inside. Yes, very nice. Fix the scope. And I will use the outer calibration to see the needle. Yes, here, this is the needle. You see it?
By ultrasound?
Yes.
While Prof. Akasha is taking the biopsy, for those colleagues residing in the Grand Millennium and Kurdistan Millennium, the checkout will be at 2 p.m., please. And
now
lunch,
this is the needle. You see the needle?
The lunch will be at 1:15 minutes.
This is the needle here.
Dr. Aras?
Yes, clear.
Yes, here, as I told you, it is sliding over the lymph node. I will try again. Yes, sliding. Then here, I can do door knocking technique. I fix the stopper 2 centimeters below the handle and give a sudden push. Now I am in very nicely. Yes, yes.
Sorry.
Okay, now the needle inside.
Shall I push?
Yes, pull.
Sir, do you do the same in-out procedure as you did to the mass? The same with the lymph nodes?
What?
Same
the same
technique.
Yes, the same technique. Yes, yes, yes. The same technique everywhere. This is the slow pull technique. Dr. Hiwa is withdrawing the stylet slowly, 5 by 5 centimeters. So he is creating a very low pressure inside the needle. And yes, and I will put the high pressure by the syringe. If blood comes, then I will stop.
Do we need
Yes.
Doppler, Dr. Hussein?
Yes.
Do
I
we
put
need
Doppler.
You did.
I have put Doppler.
No, while
Yes.
taking the biopsy.
Sometimes we don't use because the quality of the image will be decreased if you apply Doppler. The frame rate will decrease.
Yes, yes. If you apply Doppler, yes. Now blood comes. It would be a very nice. If you do the maneuver with Doppler, the movement of the needle and the movement of the lymph node against the needle will do haziness. So you apply it first before taking the biopsy, to be sure that there is no intervening vessels. Yes, if I'm taking here, شوف, you see the haziness. So not preferable to apply Doppler while you are moving the needle inside, just before. Now it is very nice.
Okay.
And I'll take it out. And this will be biopsy 2. Before taking the biopsy from the lymph node, as I told you, we flushed the channel of the echoendoscope with normal saline to clear it from any remnant of biopsies of the first biopsy from the pancreatic mass, and also flushing the needle. So now we did the lymph node biopsy, and here this is now from the stomach.
You need me to put the slide?
Yes, like the first one.
Okay.
And here this is another lymph node around the liver. Now we will examine the liver. I left you the expelling of the second. Now we are scanning the liver. Yes, scanning the liver starts from the intrahepatic portion of IBC. Yes, very nicely. This is the intrahepatic portion of IBC. Now we anti-clockwise. This is the left hepatic vein and segment 2 and 3. And this is the fish eye appearance. This is the left portal vein. And this is the ligamentum teres and ligamentum venosum. Here segment 3 and here segment 4B. We will keep examining the liver because sometimes we find liver metastasis small, not seen by CT or MRI, especially if it's smaller than 1 centimeter. And this is spleen appearing from opposite side, and this is the liver, very nicely seen. Fish eye appearance, segment 3 above and segment 4B below. I am now examining the liver. I think no metastasis could be seen here. Okay, very nice. And this is the intrahepatic portion of IBC. Now we should examine the left suprarenal. This is the lymph node. Examine the left suprarenal. This is the left kidney. Now clockwise to look at the left. And this is very nicely seen, the seagull appearance of the left suprarenal. This is a wing and this is a wing. And this is the seagull bird. This is the body of the bird and this is the wings. Very nice left suprarenal. And then here we start examine the mediastinal lymph node. And here this is this pre-aortic lymph nodes. There are multiple lymph nodes. Now we will examine the mediastinum. Very nicely seen inferior vena cava going to the right atrium. So this is station 9. And pulling the echoendoscope up, yes. This is the inferior vena cava going to the right atrium, and this is the left atrium and right pulmonary. Left atrium and right pulmonary. This is the subcarinal area at the arrow. And then 180-degree clockwise rotation. This is the azygous vein. 90-degree, this is the aorta. So this is station 8. And no lymph nodes. And here this is the subcarinal, station 7. This is a small lymph node, like a benign, because it is flat, with preserved hyperechoic hyaline, and it is not hypoechoic, elongated, preserved hyaline. So mostly it is benign lymph node, very common to be seen. Here, with the ROSA echo endoscope, this is the subcarinal, and this is the aorta. We'll keep withdrawing with anti-clockwise and up. We see the Mickey Mouse appearance. The 2 ears of Mickey Mouse, aortopulmonary. This is the aortic arch, and this is the left pulmonary, not the right. The right is in subcarinal. The left is in the aortopulmonary. This is 4L, 5, 6, and 10L. And this is the aortic arch, slightly atherosclerotic. And this is the subclavian artery arising from the aortic arch. This is segment 2L, and this is the common carotid. So segment 3A, no mediastinal lymph nodes. It is abdominal lymph nodes, pre-aortic, and at the splenic. Okay, and this is small cervical lymph node, not so important. So final diagnosis is well-defined pancreatic head mass, obstructing the CBD with plastic stent inside and obstructing the pancreatic duct, so it is mostly pancreatic in origin. It is abutting common hepatic with clear line of interface, away from the portal venous confluence of portal venous superior mesenteric vein, away from the superior mesenteric artery.
Dr. Aras?
Beside the gastroduodenal artery, there are abdominal lymphadenopathy as mentioned. No mediastinal, significant mediastinal lymphadenopathy, and the left suprarenal is free, and no apparent hepatic focal lesion.
Thank you so much, sir.
Thank you. Thank you, sir.
دكتور أراسجان لما 5 دقيقة أجا برسالة عن هي لباري هدو كيسكوا you can ask.
Yes.
And meanwhile, for the last session of live demonstration, because unfortunately we don't have time for our conference, you can see the pathological specimen of the lymph node by Ustaz Sonokasha. You can see, Dr. Aras?
Yes, yes.
Very nice.
Yes, the video is very clear. Yes.
This technique is somewhat modified, rapid on-site evaluation by microscopy, by our eye. This is very good for checking adequacy of our specimen, because if we are not sure about 100% good pathological, good gross sample for pathology, we can repeat the FNB up to many times. But usually for the, because of the new needle types, nowadays the technique of FNB, fine needle biopsy, and getting core tissue become very, very good.
Okay.
So within, yes, please.
Okay, if we...
0-0, bravo. Okay. Now going well?
If
or?
any question, please.
Dr. Aras?
Yes.
We have a very nice demonstration, but not inside the patient, in outside the patient, which is a new cholangioscopy, as I mentioned before. This type of the cholangioscopy you hope to get near future. This is a surprise of our live demonstration by a Chinese company called the Xijin company. This new cholangioscopy will open a good era for us of second space endoscopy, cholangioscopy, pancreatoscopy, for assessment of indeterminate proximal biliary stricture and dealing with a difficult intrahepatic or common hepatic duct stricture. For many cases when PTBD very difficult, we can assist our radiological friend for doing single operator cholangioscopy. This cholangioscopy is very good because done by the same endoscopist, 4-wheel direction, up, down, right, left, and we can do a lot of therapeutic intervention inside the biliary tree, including electrohydrotic or laser lithotripsy, taking biopsy, pushing snare for extracting any migrated stent. Within 1 minute, you will see the stent which will be demonstrated by Dr. Amr Al-Furi, who is also expert in pancreatobiliary endoscopy. Thank you so much, sir, for your
I
time.
have a question,
nice
Dr. for Dr. Hassan. Dr. Hassan. Ustaz
Yes,
Akasha. Is it better to take as biopsy from the lymph node by a different needle from that of the pancreatic one?
There is no mic. Dr. Hiwa, we cannot hear from it.
Dr. Hiwa?
Dr. Hiwa, لين نزيق برول Prof. Akasha. We cannot hear from.
Hey.
هسه بدك انتبه. Yes, Prof. Akasha.
No.
Assalamu alaikum.
Alaikum assalam.
You are hearing me.
Yeah.
The question is why not use 2 needles? This is ideal.
Yes.
It is ideal if you can do it, but the needle is expensive. The needle is expensive. In my country, it is expensive.
In my country, also very expensive.
And here also is very expensive. So if the patient is rich and can pay for 2 needles, this is ideal. If not, as I told you, we may start from the lymph node first and then the pancreas. Opposite to what we did. Because we flushed the needle with saline, we can flush the needle with saline after the first biopsy and flush the echo endoscope with the saline, then to go to the second lesion.
The irrigation.
If you don't flush the needles or echo endoscope and you want to work rapidly, then you should start by the lymph node first. Because if you start with pancreatic head mass and it is a malignant mass, and then the lymph node, you can contaminate the lymph node by the first biopsy.
Yes.
It may be a benign one, not necessarily it to be malignant. There may be a primary adenocarcinoma of the pancreas with multiple benign inflammatory lymph nodes. So if you start with the pancreas first and you didn't flush the needle and the echo endoscope with saline to expel the rest of the material, and then go to the lymph node, you may implant some of the malignant cells inside the benign lymph node. But if you start with the lymph node, if it is benign, then it will not contaminate the pancreatic. If it is malignant, it will not contaminate the pancreatic, because the pancreatic, sure, it will be malignant, because it is the one tending this malignant lymph node.
Very nice.
But in the clinical practice, you start first visualizing the primary mass. Then, logically, you start sampling what you see first.
But
and after that, go up to complete your staging, and you surprise that it is a suspicious lymph node. I should take it.
But there is another important point. We'll come to this in this case. According to your assessment by endoscopic ultrasound, this patient probably resectable or borderline resectable.
Yes.
And usually, when we do FNB for the pancreas, we do transduodenally. The surgeon removed the duodenum with a Whipple's specimen.
Yes.
But when we see a lymph node in the gastric area, we go transgastrically. Transgastric, we puncture the lymph node.
Yes.
And there are theoretical risk of seeding of the needle when we go for a case of resectable pancreatic cancer. Is this puncture of the lymph node, perigastric lymph node, make the procedure unresectable later? And what are the risks of seeding, theoretical,
seeding.
In this case?
A very important point. The risk of seeding is minimal, and no one all over the world believing in this seeding theory. But in cystic lesion, in mucinous cystadenoma, in malignant cystic neoplasm, it may have some importance. So, according to Japanese guidelines, they don't like to sample pancreatic body and tail cysts because they are sampled from the stomach. And you don't remove the stomach during the distal pancreatectomy. But this is for cysts.
Yes.
For
may see the
yes, the puncture site and the pressure is high, and then 1 or 2 drops may seep through the puncture site. Drops of fluid. So, some papers saying that the incidence of seeding is less than 1% for solid masses and more than 5% for cystic masses. So I refrain to sample cysts from the stomach.
Yes.
Pancreatic body and tail cysts. But also a European sample is from.
Thank you so much.
So no one believing now in seeding theory.
Thank you so much for your nice demonstration. Thank you for your attendance. Dr. Aras, we have just a few minutes before going to the to come to end of the live demonstration here. We have just as I said, Dr. Amr will present the colonoscopy.
Yeah.
Please shift to other camera. You will see that there is a very nice colonoscopy. Dr. Amr. Okay. Dr. Aras.
Yes, yes. We can see it. Yes.
Yes. Dr. Aras?
Yes, yes, we can see it.
You see us?
Yes,
you see
yes,
us?
yes.
And you hear us?
Yes.
Okay, Dr. Amr.
Yes.
Me and Dr. Hiwa, we're going to demonstrate one of the innovative endoscopy in the hepatopancreatopillary device, the colonoscopy. And this is from Seagen company. As we see, this is the processor, including the screen of the view of the endoscope. And the scope is very, very thin. In order to work, we go through the working channel of the ERSP. One of the advantage of this device that its tip is very, very flexible to go through the working channel of the ERSP. This part is stiff and this part is very stiff, very flexible. And the advantage of this thing, as we see, that we could avoid the injury with the sharp angles that might happen using the elevator of the ERSP, or during cannulation when you are looping the scope outside the papilla to enter into the bile duct. This will give you a lot of stability and safety for the tip of the scope, not to break down this very minute fibers of the colonoscopy. At the end of the colonoscopy, we have a source of light, as you see here. If we close the cameraman to the device, this is the source of light, and there is a working channel which is 1.2 milli, as you see here, applicable for multiple interventions we might do during the ERSP, like snare. As you see here, open it, Dr. Hiwa. If you close the view, you could see the very, very small part. You see it, the tiny part of the snare through the colonoscopy. And we have also biopsy, forceps, and we have also basket.
For the audience, imagine this scope will go through the duodenoscopy scope, because we have some of our colleagues, maybe not pancreatobiliary surgeon or gastroenterologist.
Yes.
This scope, which is 9 French, go through the duodenoscopy scope and go into the intrahepatic.
Yes.
Into the intrabiliary, and scope inside the scope by single operator, by the one endoscopist.
The same endoscopist.
And through this channel, we can take biopsy from the proximal cholangiocarcinoma if we suspect.
You could reach with this scope up to the intrahepatic branches, the main right and left ducts. You could see very good the cystic duct origin. We could examine the CBD from its proximal and distal end. Also, we could use it as
examination for the pancreatic duct because it's very, very thin to enter through. And these are the accessories, like the biopsy. If you see intraductal lesions, like cholangiocarcinomas or something like that, you need tissue biopsy.
Very small.
Yes, it's very, very tiny and small bites. You could get an impression about the biopsy, histopathology for the examination and the diagnosis of the lesion you have seen. Also for intervention, you might see small missed stones or impacted stones. We could use the electrohydraulic lithotripsy and remove them, or even the very tiny basket. You could imagine that this working channel is 1.2, and the working channel of the ERCP duodenoscope could receive the shaft of the main scope. So you are working through a small working channel, working through another working channel of the scope.
So it's
As
a baby,
Dr.
it's
Hiwa
a baby
mentioned,
scope. It's a baby scope.
It's baby scope. It's 3 millimeters.
But it's
in
a
diameter.
single operator, Dr.
Single
Nawab.
operator, yes. As you
It
see here,
makes
this rubber band will keep the endoscope attached with this band to be surrounding the shaft of the ERCP, like this. So, could you hold this for me? So if I am working with the ERCP, this cholangioscopy could be attached to the ERCP. And at the upper part, I have the wheels of the ERCP machine, and the lower part, I have 4 directional movement. And this is one of the innovative technology. I have up and down, as you see, and I have right and left with sharper angle. And this would help you to assess thoroughly the intraductal branches, because sometimes you have tumors, strictures, stenosis, and you need to make a very sharp angulation without hurting the tip of the scope. So this flexible end give you like the looping part, and these 4-way wheels could help you to get this sharp angulation to go very deep and to diagnose some of the challenging intraductal tumors. What is important here, also we have here a couple of buttons at the cholangioscopy for the magnification. If you look here, this is 1 degree magnification, zoom, more, 2, 3, 4, 5 degrees of magnification to assess if you have intraductal lesions like papilloma or something like that. Also, we could have a dual aspect if you want to freeze what you have seen and to get a live screening. So this is another mode available with the this
easy to handle.
Yes, it's easy. That
can be transmitted from one hospital to other.
Yes, this is portable, could be portable, and this is easy to be used as a single operator. So this is a lot of advantages for any advanced endoscopic unit with the hepatobiliary pancreatic facilities.
So thank you, Dr. Umar, for this clarification. Thank you, Dr. Hiwa, for this nice cholangioscope. Yeah.
Dr. Aras.
Yeah.
Dr. Taha, he want to ask few questions. Although Dr. Taha, our mentor, he did baby scope cholangioscopy. I remember 15 years ago in our center when he started. Dr. Taha, please. When he started doing ERCP for the first time in Kurdistan and Suleimani. I remember when I was a board student in medicine, he was doing every week few cases of baby scope.
My question back to the developing country, can we use it more than one time?
No. In Germany, we are tertiary center for cholangioscopy and transplantation. So the advantage of this machine outside, it's a single operator. And the second thing, it's a single use. But the point is, it's very expensive, and it was not durable because of the very sophisticated and very thin technology. So when it's get broken, it might cost the patient 1,200 euros, for example, per examination. But yes, please.
Second question. What is cortical embolism? You need to use CO2?
No, in this scope, we are not using any air. So the normal way of examining any lumen, you might inflate air or CO2. But with this cholangioscopy, the inflation is by water irrigation. So we just have a water pump connected to this one of these two sides. One is for suction, and the other is for inflation. Just I connect this to the water pump and just put my foot on the bed. It irrigates the water inside the biliary system, and then also the water has an extra magnification image for any lesion with good demonstration, especially when you have a stricture. Working underwater is very fascinating, as you see. Yes. So it's one of the main important things that you see with water irrigation.
Ustad Amr, I asked our radiological intervention colleague, Dr. Nasser, he's doing many PTBD in our center. He said this will be very good for me also, because this is just non-French. He said I can go through the puncture of the liver, and we can deal with some type of the tight stricture if we cannot do, especially after Bilros 2 surgery, after bypass surgery. He can go and he can, we can use laser.
Definitely, I do agree with you. You could use this machine, this cholangioscopy, either through the ERSP working channel, number one. Second indication, percutaneous, but you need to work through a working wire. You put your wire inside the biliary system, and you go with this initial insertion with this cholangioscope. The third thing, you could use it intraoperative for staging, or example, or use it through any direct incision. So we could use it in any different manner, whether through the endoscope or percutaneous or intraoperative.
Dr. Aras, I think our time is over. So we like to send you a big wish for the rest of our conference. And I'd like to thank our colleague and our teacher, Dr. Ustad Sanukasha, for his nice demonstration. Ustad Ahmed for his kind, very nice, beautiful demonstration. Ustad Amr, Ustad Dr. Takar Bouli for a nice demonstration. And the rest of our team, Dr. Mohammed Lek, Dr. Marwan, Dr. Ahero, our big support from Siemens Company. And I'd like to send our special thanks to our anesthesia team, Dr. Rabah Khan, please, because you saw in the demonstration there is no any kind of irritation of any problem during the procedure, which is very essential for third space endoscopy. And I'd like to thank Anwar Sheikh Hospital for their kind help and support of our demonstration. You see a very beautiful operative room and theater. Everything is in advanced, high quality, which you don't see usually in our daily practice. Great thank for them. I like also to thank our technical team, which they did amazing transmission of our live demonstration. Big thank for our nurse, for our assistants, which all help us in doing this procedure. I think we did, yes.
Thank you for you. And
we
want from our hall to a strong applause for this wonderful team. Prof. Akasha, Dr. Umar, Dr. Makhdour, and others. Well done. We learned a lot of from your experience, and we hope for the next year we will see you again.
We are doing more cases. We have many cases, but we cannot transmit to you. So please enjoy the rest of the day, and we will do more work here, inshallah.
Okay,
thank you so much.
Thank you.
Bye-bye.
Bye-bye.
Thank you so much.
Lunch almost started, and those colleague guests is coming outside from the Suleimani. The checkout of both Grand Millennium and Kurdistan Millennium will be before 2 p.m. Please. Thank you. Thank you for all.